All right, this PowerPoint is all about exam 2 for our Nurse 335 course. This will cover FA Davis chapters 8, 9, 10, and 11. I'm going to switch up the order that we look at these chapters. We're actually going to be starting with chapter 9 first. I stumbled across some of these different random good things to know about OB for the NCLEX, and I wanted to include them within the slideshow just because I thought it was pretty relevant to what we're going to be talking about with this exam here. I got these all from a live review that you guys will take when you're in 9th semester, but I thought it was pretty relevant again to what we're going to learn. So it is these will make sense as we're going through the lecture, but it is never good to be late. Okay, this is meaning for late decels, that's a bad sign. Absent variability is considered a critical finding. Never place a laboring patient flat on her back, that one you should already know. Unexplained pain in a labor and delivery patient is not good. Okay, we know labor itself it hurts, okay, but this would be unexplained. So preterm labor could be a sign of a placental abruption, an amniotic fluid embolism, or a uterine rupture. So we need to assess and figure out what's causing the pain. The fifth random good thing to know is never provide fundal pressure with shoulder dystocia. If you have an OB client that is tachycardic, assess or think a possible hemorrhage first, and then if not, it could be a sign of an infection. Meds used for a postpartum hemorrhage include oxytocin, methergonavine, carboprost, and misoprostol. If your patient all of a sudden has a quick onset of epigastric pain, a lot of times that's associated with eclampsia, or she's about to seize on you. When we give oxygen to moms in labor, it should be administered via a non-rebreather face mask at 8 to 10 liters per minute. And then whenever a patient is in pain and if she asks for pain meds, yes, we can give her pain meds, but we should also try to incorporate non-pharmacological, kind of use them together. And then this is one other slide that I wanted to include from that same live review. So just some standards of care for OB patients. First, never perform a vaginal exam in the presence of unexplained vaginal bleeding. The reason for that, think back to exam 1. If you don't know why she's bleeding, could it be due to a placenta previa? If you do have a patient that's bleeding, we need to get IV access. The third standard of care is RhoGAM. We've talked about this a lot of times, but we give this to our RH moms. If they've had a miscarriage, we give it prophylactically at 28 weeks. And then after delivery, if we know what baby's blood type is, if it's positive, we're going to give her additional RhoGAM within those 72 hours. It's also considered a blood product, sorry, not produce, let me fix that, and cannot be delegated to an LPN to administer. And then the last thing, unstable clients should be roomed close to the nurse's station. Okay, we're going to get started. Again, I switched up the order. We're going to start with chapter 9, fetal heart rate assessment. This slide just lists some general terminology that's good for you guys to know. Baseline, so this is the fetal heart rate rounded to increments of 5 beats per minute, and we look at a baseline during a 10-minute time frame. So we take a 10-minute strip, we're going to look at it, what's the average, and record it in an increment of 5. A normal baseline for a fetus is 110 to 160 beats per minute. An acceleration, this you should remember from exam 1. So an acceleration is an increase in our fetal heart rate of at least 15 beats above that baseline, and it stays off of our baseline for at least 15 seconds. So if we have 2 or more accelerations, we can say we're reactive. If we have 0 or 1, we're non-reactive. Tachycardia, just like in a normal human, right, is when your heart rate is fast. So tachycardia for a fetus is when our baseline is greater than 160 beats per minute. Bradycardia is when that baseline is less than 110. Some other words, variability. So this is defined as the fluctuation in the baseline fetal heart rate. So it's, to me, this is the most confusing one to understand, but it's the beat to beat variation. We record it as absent, minimal, moderate, and marked. Again, we'll go deeper into this on the next few slides. And then we have decelerations, and these are drops in our fetal heart tone below the baseline. And there's 4 types of decels we're going to learn about: early, late, variable, and prolonged. When we are looking at fetal heart tones, there's a couple of different ways that we can monitor the fetus. So we have intermittent or auscultation. This is where we just listen for a little bit of time, and we can use this on patients who are low risk, meaning there's no risk factors, they're term, there's no issues with the mom or the baby. We're not giving her any medications at all to induce mom. This is where we use like the Doppler, okay, the handheld Doppler where you just put it on her belly. There's no paper record if you do this way, okay? So like what you have to chart it as soon as you get it, because that's the only way that you know exactly what time it happened and that it happened. This can tell you some things about the baby. It can give you a general baseline. You can hear a rhythm, and then you can also identify if you hear any changes going on. If you are using intermittent or auscultation, you want to listen between contractions, during a contraction, and after a contraction. So you kind of hold it on there for a while, because that's when we can see baby's heart rate drop, is during those times. If you notice anything concerning or abnormal, then you want to hook them up to like our external fetal monitoring. This is what we practice in Skills Lab when we hook her up. That's what this picture is all about. So this offers continuous monitoring. It gives us a paper record. It helps identify baseline, accelerations, decelerations, variability. So if we are inducing a mom or if she's high risk or anything like that, this is a type that's recommended. Now, sometimes we can't get our heart tones to pick up this way, but we need to know, what does our baby look like, or how is it handling this? So if that's the case, what we can do is we can place internal monitors. These are known as a fetal scalp electrode, or an FSE, or an IUPC. In order to place either of these, her water must be broke. You don't want to use internal ones if mom is HIV positive, if she has an infection, herpes, if she's group beta strep positive, or if there's a previa. And this can also tell us exactly how strong our contractions are. So this one, all I really want to point out here is I have pictures on here, so our intermittent or auscultation. This first one would be a fetoscope, what they're using. So it's like a stethoscope, but it listens directly to the fetal heart rate. And then Doppler is down there on the bottom. All right, so here is our internal monitoring. You can see this little cord connected onto the fetal scalp. So a fetal scalp electrode, it's a little wire that gets screwed in underneath the fetal scalp. This will directly tell us baby's heart rate. Okay, it's like an electrode directly connecting the fetal heartbeat. So that is an option. Now think, we're puncturing the skin of this fetus. That's why they say, if there's any infections or anything like that, you don't want to place this, because now we've just punctured the skin, made an easy opening for that bacteria to get directly in underneath the baby's scalp, right by the brain. An IUPC, an intrauterine pressure catheter, is something that can get placed. I have one of these I'll show you in Skills Lab. This can get placed, and it tells us exactly how often and how strong her contractions are. So sometimes when we're using external monitoring and we're using the TOCO, maybe we can't get her contractions to pick up correctly. Or maybe we need to know exactly how strong they are. let's say she's been stuck at 7 centimeters for 2-3 hours, okay? We're giving her oxytocin. She's contracting adequately, we think, every 2 to 3 minutes, but her cervix is just not changing. When we look at the strip, we can't tell exactly how strong those contractions are unless we place an intrauterine pressure catheter. This will directly tell us how strong those contractions are. And we can measure it in what's called Montevideo units, or MVUs. This IUPC can also be used. We can infuse fluid back into the uterus if needed. It's called an amnio infusion, and we'll talk about that a little bit later too. So Montevideo units. So if a patient has the intrauterine pressure catheter placed and we're looking at her strip, what we can do is now is where we can use the numbers on the bottom to tell exactly how strong her contractions are. So what we do is we take 10 minutes worth of a strip, and we add up how high each contraction goes. So if you're looking at this first one, you'll see this peak. It goes up to about 95 millimeters of mercury, I believe. Okay. The next one but you see how they say it's 75 millimeters? That's because we have to minus where the baseline pressure is at. Usually the baseline is at 20. So we're going to go 95 minus 20 gives us 75. We're going to do this for each contraction during that 10 minutes, and then we're going to add all them up. So when they added these 4 contractions up, they come up with 230 MVUs. That's adequate, okay? To be good, strong contractions, you want it to be between 200 to 300 MVUs. That means we're having strong enough contractions that we should have good labor progression. All right, we're going to start looking now at fetal heart tones. But before we do that, we need to realize what are some different things that can influence our fetal heart rate. So some different things that can influence how our fetus responds during labor and delivery is, do we have enough adequate blood flow to our uterus? Is there sufficient placental area? Is our umbilical cord unconstricted? Those 3 things all make sure that there's effective transfer of oxygen to the baby and CO2 gets removed from the baby. So think of some reasons why maybe these would be effective. Adequate uterine blood flow, okay? Maybe mom has hypertension and her vessels are constricted, therefore we're not getting enough blood flow to her uterus. Maybe she's laying directly on her back or just got an epidural and her pressure tanks. We're not getting enough blood flow to her uterus. Sufficient placental area. Okay, so maybe we have a placenta abruption going on where part of the placenta has come off. Maybe she's a smoker and it's killed off some of the placenta. Okay. Other things that can influence our fetal heart rate is if we have appropriate fetal oxygenation. This is all affected by mom's oxygenation. So do we have adequate O2 for our mom? Again, adequate blood flow to our placenta. Adequate circulation between the uterus and the placenta. Adequate umbilical circulation. And then also, is the fetus able to regulate its fetal heart rate? So a preemie baby, its parasympathetic and sympathetic nervous system are not developed enough, therefore it can't regulate it. Okay. So if we're looking at a strip of a 24-weeker, there's certain things that, even though they would be concerning on a full-term baby, it's normal for a 24-weeker because its nervous system isn't developed yet. Another thing you want to know is that when we're looking at heart tones is something that's called fetal reserves. This is defined as the degree of hypoxia or oxygen stress that a fetus can tolerate before bad things happen. Okay, so think of it like if you're reading through this, like a backup oxygen tank. Okay, it's something that healthy, normal babies have. They have a backup oxygen tank. So as they're going through the stress of labor and the contractions and everything like that, if they need extra oxygen, they have this reserve tank. Well, sometimes what happens is they use up all this reserve, okay? Or maybe their oxygen tank wasn't very big to begin with. If that's the case, what you can start seeing is what's called late decelerations. This is a sign that these reserves, this fetal reserves, are being depleted. We're running out. We're running on E. Okay, think of it as your gas light just came on. Once that gas light comes on and those fetal reserves are completely or fully depleted, this fetus is now at risk for injury the longer that it stays inside mom. So if we keep having these type of decelerations that are called late decels, and they keep reoccurring, that's a bad sign, and we need to get this baby out before we cause some serious injury, sometimes injuries that we can't fix in the long run. All right, so let's start looking at fetal monitoring strips. This one just kind of gives you 7 different steps of how or what you need to do when you're looking at a strip. So first, we're going to determine the baseline. Everything is determined off of what our baseline is. Then we're going to look for accelerations, variability, contractions, decelerations. Then we're going to do something called POOF interventions and then categorize it. So let's look at each of these in more detail. All right, baseline. This should be a review for you, but baseline is your average fetal heart rate over a 10-minute period that's recorded in increments of 5. Again, your normal baseline is 110 to 160. When you're looking at baseline, do not use any accelerations or decelerations. So don't look at that for your baseline. It's the time or the heart rate in between that time period. So if our baseline goes above the normal 160, and so we're greater than that, we now have tachycardia. Some common causes of fetal tachycardia would be fever in the mom, exposure to medications like terbutaline, one of the medications that we give, one of our tocolytics to stop contractions. Well, now it can increase the fetal heart rate. Fetal hypoxemia, so a baby that's not getting enough oxygen can cause its heart rate to go up. Infections, dehydration, anxiety, anemia, and illicit drugs. If you notice tachycardia on the fetal monitoring strip, assess mom for any signs or symptoms of infection. Check her temperature. It's the most common reason, especially if her water's been broke for a long time or if she's been in labor for a long time. These are reasons that she might have an infection, and you'll see that with the fetal heart tones. The opposite of tachycardia is bradycardia. So this is where our baseline is less than 110. So on this strip here, you'll see this blue box. That would be your normal baseline in there, 110 to 160. Our baseline on here is less than that. It's more around 90. So our baby's heart rate is low. Some common causes for this would be if mom is laying in a supine position, if mom's dehydrated, if she herself has low blood pressure or hypotension, if she's experienced a cardiac arrest or a seizure, if the uterus has ruptured, so it's, blown up into pieces, a placental abruption going on, or there are some medications, think of sometimes some blood pressure medications or things like that that can cause bradycardia in our fetus. This is something where we need to intervene. A fetal heart rate less than about 70 is not good at all and can cause severe compromise in our fetus, and so bad where we could lose the baby. So if you see a low baseline like this, we need to do something and figure out what's causing this, as it's not a good sign. Accelerations, this should be a review from exam 1. So once you know your baseline, we can look for accelerations. This is where the heart rate goes up at least 15 beats higher than our baseline, and it's off of our baseline for at least 15 seconds. So if you look at this strip, there are lots of accelerations on here. These are a good sign, a good indicator. It tells you your fetus has good oxygenation. It's definitely a good sign. The third step we want to look at when we're looking at a fetal heart tones is we need to figure out what's called our variability. So variability is fluctuations in the fetal heart rate baseline that are irregular in amplitude and frequency. I like to describe this as the jiggliness of the line, okay? Fetal variability is the most important predictor of adequate fetal oxygenation and that you still, have good fetal reserve left. Okay, so variability is if you have good variability, which is moderate is what we want to see, you can say you have enough oxygen left and your fetal reserve is good yet. Okay, so we have 4 different types of variability. Absent variability is where there's no change from one fetal heart rate to the next. So it's like a straight line, okay? This means this is not a good sign, okay? So you have absent. Minimal variability is where the beat-to-beat change is less than 5 beats per minute of a difference. Okay, so for example, if we were be looking, this strip isn't very great here, but let's say we're looking at our line and we have a heart rate of 121. The next time the heart beats, it's 117, then it's 120, and then 116. See, the change from each beat is less than 5. That would be minimal. Absent and minimal variability can occur with a sleeping baby, with sedation. So if we've given mom some sort of, fentanyl or something like that, it can cause a sleepy baby. Magnesium sulfate, CNS injury, fetal hypoxia, and acidosis. Other things would be supine hypotension, cord compression, tachysystole, drugs, or prematurity. So it's not a good sign, okay? Again, it's telling us that we're running out of oxygenation and our fetal reserve tank is almost on E. Moderate variability is what we want to see. This is where the change from one beat to the next is from 6 to 25 beats per minute. Okay, that's what we want. Marked variability is where from one beat to the next, it's greater than 25. It almost looks like constant accel, decel, but it's variability. This is not a good thing. Okay, it's also another sign of fetal distress. So this slide kind of lets you see the variability a little bit better. So the top left, you'll see there's really no change from one heartbeat to the next. It's like a straight line, correct? That would be absent variability. The one below it, in the bottom left corner, you can see there's a little bit of change from one heartbeat to the next or one heartbeat to the next, but it's not a lot. It'd be less than 5, so that's minimal. Moderate is your top right, and you'll see the jiggliness of your line there is beautiful. It's at least between 6 to 25 beats of change. That's what we want. And then the bottom right is our marked. See, it's up, down, up, down. That's marked variability. A special type of fetal tracing that gets put under variability is something called sinusoidal. If you're looking at this pattern, you'll see it's smooth waves, right? It's, I can't think of the word inundulating, but it's smooth wave pattern. This is a bad sign. This is due to fetal edema usually. So your baby basically bled out internally or doesn't have enough blood left. This is an automatic bad, bad baby. We need to deliver stat. You're close to having no heartbeat at all. Well, this pattern makes it an automatic category 3, which we'll talk about at the end of this slideshow here. Okay, after looking at our variability, the next thing we want to look at is contractions. So now we're moving down to the bottom part of our fetal strip, and we're looking at to see when she is contracting. So there's 4 things that we look at with contractions. The first one is frequency. Frequency means how frequent or how often is she contracting. So we can measure that by looking at the start of one contraction and seeing how long of time it lasts until the next contraction starts. Okay, so from the start of one contraction until the start of the next. A normal frequency pattern is she's contracting every 2 to 4 minutes. Roughly, that would equate to 3 contractions in 10 minutes. Duration means how long does one contraction last? So you look at the start of the contraction and count how many seconds it goes until it ends. Normal contraction lasts from 40 seconds up to 110 seconds. The intensity of a contraction, remember when we're using our external monitors, we need to put our hands on their belly to see how strong that contraction is. So when she is contracting, if you put your belly on where her fundus is, you feel, and mild contraction palpates like your nose, a moderate is your chin, and a strong is your forehead. Normal intensity, you want it to be moderate to strong. If she does have internal monitors on, with that intrauterine pressure catheter, we can measure the Montevideo units, the MVUs, and remember, good MVUs are 200 to 300. The last thing we look at with contractions is the resting tone. Resting tone or resting time is the amount of time where the uterus is relaxed at rest. This is the time in between contractions. So once a contraction ends, you count all the way up until the next contraction starts. You want this to be at least a minute long, at least 60 seconds, as that's the time when the baby is getting reoxygenated and getting the blood supply back when it's not during a contraction. So the last slide told us what normal contractions look like. But what happens if we do more than that normal contractions? Then we get something diagnosed as called tachysystole, too many contractions. So either our frequency is too often, we're having 6 or more in 10 minutes. Our duration, the time it lasts, is it's lasting longer than 2 minutes. The intensity, okay, the strength of our contractions, our MVUs are greater than 400, or our resting time is less than 60 seconds. So any of those 4 things, when we look at frequency, duration, intensity, or resting time, any abnormalities with that is diagnosed as tachysystole. So we get concerned with that because every time the patient has a contraction, it cuts off the blood supply to our baby. So things that we want to do is we want to try to limit these contractions. So we're going to change position. Okay, roll mom. Stop any medications that might be causing contractions. We can give her an IV fluid bolus. Try to reduce her pain and anxiety. If needed, we could give a tocolytic like terbutaline. And then we want to notify the provider, because if our baby's heart rate hasn't declined yet, it will very shortly. Okay, after we look at contractions, now we can look at decelerations. So there's 4 different types of decelerations, and in class I'm going to help you walk through how to correctly identify these a little bit easier, but I want to talk about each of them, their definition, and what are some causes. So the first deceleration is prolonged. So with a prolonged deceleration, we have a drop in our fetal heart rate from baseline. It drops by at least 15 beats per minute, and it lasts between 2 to 10 minutes. Okay, so it's a very long, a prolonged amount of time that our heart rate is down. This can be due to a couple of different things. One, tachysystole, so too many contractions, hypotension in mom, placental abruption, cord compression or prolapse, or vagal stimulation. Okay. Our next type of deceleration, this is the most common. This is called a variable. Now do not get this confused with variability. Okay, very similar words, but different meanings. A variable deceleration is where we have a drop in our fetal baseline by at least 15 beats per minute, and it lasts at least 15 seconds. So basically, it's an upside down acceleration. Okay, an accel goes up 15 and lasts 15, a variable goes down 15 and lasts at least 15. Another thing with a variable decel is that it takes less than 30 seconds to reach the nadir. The nadir is the lowest spot that your heart rate meets during the deceleration. So when we do this in class, we're going to identify where the nadir is, and we're going to count how many seconds it takes to reach that. If it's less than 30 seconds, it's a variable. Variables are abrupt. They drop fast. That's why it takes less than 30 seconds to get to the lowest drop. There's something that are called shoulders that are usually present. Okay, and I'll show that in a couple slides here. Common shapes of the decels, since they're abrupt, they drop down fast, so it looks like a V, a W, even U-shaped. Variables can occur without a contraction, or they can occur with one, and again, it's the most common type of decel. The final two types of decelerations are early decels and late decels. They are very similar in how they look. Both of them must occur with a contraction. They both take at least 30 seconds to hit their nadir. Okay, so these ones take at least 30 seconds, where our variable takes less than. The difference is, and it's an early decel, is that the nadir, so the lowest point of our deceleration, occurs at the same time as the strongest part of our contraction. It almost looks like a mirror. Okay, early decels are caused by the fetal head getting compressed. So it's getting lower and lower and squeezed more. Think of it as like a big hug. It's due to an increase in the intracranial pressure within that fetus. It's a good sign. It means that she's getting close, if not to being complete already, and it's going to be time for a delivery. A late deceleration, however, is a bad sign. It's a sign of fetal intolerance to labor. Our fetal reserves are on E. And this occurs when the nadir occurs after the peak of the contraction, okay? So the nadir occurs later, and that's a late decel. Let's look at some examples. So when we're looking at a strip and we identify that there's some decels occurring, we need to really identify which type it is, because as you've seen on the other strips or the other slides, different things can cause different decelerations, and not all of them are bad, right? An early deceleration is okay. So how do we go about identifying what type of decel it is? So there's 6 different steps that can walk you through how to identify which type of decel it is. So, excuse me. I'm going to go to the next slide and work through these with you, okay? One second. So if you look at the steps on the previous slide, it states the first thing that you should do is place a dot on the spot of your heart tones where the fetal heart tones drop below your baseline. So we're going to say the baseline here is about 145-ish or so. So I'm going to place a dot Okay, it's in blue, where my heart tones start going below that 145. The next thing I'm going to do is I'm going to place a dot to when they come back to the baseline. Way over there. All right, now I want to know in time how much time passes from this first dot all the way over to, stop too far, to the second dot. So that's about 1, 2, 3, 4, almost 5 minutes. Okay. If your decel lasts longer than 2 minutes or 120 seconds, it's an automatic prolonged decel, and that's what we have here. Okay, so you'll see on that sheet of paper, if your decel lasts longer than 120, you are prolonged decel, you're done, you've identified your deceleration. Okay, so let's look at ones where maybe they don't last those 2 minutes. So here's a strip where when we're looking at it, if we choose a we notice that there's decelerations. I'm going to put a little dot. So same thing, first step, put a dot where it leaves baseline. I wish my dots were a little bit bigger, to where it's back to baseline. Okay. All right. How long does that take? A little hard to see here. Maybe when it's a little bigger, you can see it, but it's about 10, 20, 30, 40, about 50 seconds. Okay, so we're less than 120 seconds. So now we need to move on to our next step. The next step says to put a dot on your nadir, the lowest point of your decel, which is about right here. Okay, now we want to know in time how long it takes to get from here to, and I'm going to draw a straight line up because it makes it a little bit easier to see. Okay, how much time occurs here? It's about on here about 20 seconds. Okay, so if we can hit our nadir abruptly and fast and we hit it before 30 seconds occurs, we are a variable decel. Bam, done. We don't need to go on to the next phase, okay, or the next step of it at all. So these are all variable decels. You will see that they are shaped kind of like V's, right? Down, up. Here's one more like a U, kind of comes down and then goes back up. These are very common signs of, or very common looking variables. You'll also notice they look almost like little accelerations, like before and after right here. These are those shoulders that I was talking about. Okay, here's another strip that we're going to look at. So starting over again at question or step number 1, okay, marking where we leave to where we're back. How long does it take? Maybe 80 seconds. Okay, so we're not a prolonged. We need to go on to the next step. I'm going to place a spot where my nadir is. Okay, how long does it take to get from here to my nadir? Okay, so time this way. We are 10, 20, we're about 40 seconds. So that's more than 30 seconds, so we're not a variable. Now we need to move on to our next step. The next step says to place a dot, we're going to look at our contractions, place a dot where the strongest part of your contraction occurs, okay, and draw a line up, okay. What this is looking for now is where does your nadir occur related to your strongest part of the contraction. If it occurs at the same time, we are an early decel. Okay, and this one occurs at the same time. So this is an example of our early decel. Here would be an example of our late decel. Okay, we mark again from when we leave baseline to when we're back, we're less than 120. If I'm looking where my nadir occurs, it's more than 30 seconds in time. Now I need to draw a straight line up from my contraction up. Do you see that my nadir is occurring later? These are now late decelerations. Again, we will look at these extensively in lab, in class, until you get the hang of reading heart tones. So once we look at our fetal heart tones and we identify, our baseline, accels, contractions, variability, decels, now we need to figure out what we need to do about it. So there's this lovely little veal chop mind to kind of help you figure out what's bad with our heart tone, what's causing it, and what we need to do. So you'll see how the words veal, chop, and mine are written vertically next to each other. So this helps you figure out that V stands for a variable deceleration. Variable decels, remember that abrupt drop. This is due to the cord, the umbilical cord being compressed. Okay, can be due to baby laying on the cord hanging out of mom's vagina, wrapped around baby's neck, but something that causes like an abrupt stop in blood flow to our baby. What we want to do for this is we want to reposition mom. Okay, usually left lateral is the best. Our next fetal heart rate pattern stands for the E for an early deceleration. This is caused by head compression. And all we need to do for this is we can identify her labor progress. Okay, we don't need to reposition. We don't need to do any other interventions. We can check mom if we want and see what her cervix is at. A stands for an acceleration. These are okay and no interventions are needed. And the L stands for late deceleration. This is due to an insufficient placenta. Our placenta is not working adequately. Okay, so maybe we're not getting enough blood supply to our placenta due to hypotension, medications, positioning. And then we need to execute interventions because we know late decelerations are a sign of poor fetal reserve. We need to do something. So when we start doing interventions, these are considered intrauterine resuscitation. Okay, we're resuscitating our baby while it's still inside the uterus. Our goal is to figure out ways to maximize the uterine blood flow, umbilical circulation, and the maternal fetal oxygenation. So you might hear it referred to as POOF interventions. P for POOF, position change. Okay, change mom's position. This can minimize or correct any cord compression. So if she's laying on her right side and maybe baby is laying, on that right side too, pushed up against the cord. If you switch her to her left side, that can help alleviate that cord compression. Position change can also decrease how often she's contracting. It can improve the blood flow to her uterus and it can correct mom's hypotension. Okay. First thing you always do with issues, position change. The O stands for to shut off oxytocin or any other medication that might be causing contractions. So really what we want to do is decrease or stop contractions. So if she has dinoprostin or misoprostol in her system, we want to get that out. Okay. We could potentially even administer some terbutaline to stop contractions. We can apply oxygen with a non-rebreather mask. This will help improve fetal oxygen status. It's kind of on the fence if this is considered best practice or anymore. If your baby does improve, then definitely use it. But if there's no change, they recommend not using it. Also, if mom's pulse ox is 100%, giving her more oxygen isn't going to do anything. And then the last thing is F for fluid bolus. This maximizes the volume that mom has within her blood vessels and it helps improve the perfusion to the uterus and the placenta. It can also correct hypotension. So those are your POOF resuscitation that you can do for heart tone issues. Some other interventions that we can do. One is called an amnio infusion. So remember before I said if she has that intrauterine pressure catheter measuring how strong her contractions are, we can also infuse fluid back into mom. So this can be used, let's say mom's having a whole bunch of variable decels due to cord compression. We can infuse fluid back in around the baby to make that cord be more buoyant, so it kind of floats around and it's not just like stuck up against the uterus and the baby. So that's something we can do. We can check mom, right? We can reduce her pain and anxiety. If she's pushing and we're having issues, let's alter how she pushes. Maybe try a different position. Maybe try pushing every other contraction. They could also potentially use a vacuum or a forceps to help deliver the baby. But if our heart tones get bad enough, then we're going to want to prepare for a C-section. Once we do all those things, the final part of looking at our heart tones is now we need to categorize it. So we have 3 different categories. We have category 1, 2, or 3. Basically what this is it's a universal way for people to distinguish how well or how bad the fetus is. So if you call the provider and you say, my baby has a category 1 strip, okay? 1 is green. Green means good, let's go. You need to have all of the following in order for a category 1 strip. We need to have moderate variability, a normal baseline between 110 to 160, no late decels or variable decels. Earlies you might have, that's fine, because remember, they're okay. And you might have accels, you might not, okay? But if you have a category 1, you have a normal fetal acid-base balance. Now I want to switch to the red box or the red circle. This is a category 3. This is predictive of abnormal fetal acid base, and we need to expedite delivery. In order to be a category 3, this is a bad baby, okay? You need to have the following. Absent variability with any of the following, either recurrent late decelerations, recurrent variable decelerations, or bradycardia, or that sinusoidal pattern automatically makes you a category 3. If you don't meet category 3 or category 1 requirements, then you're automatically a category 2. Okay, category 2, you're not quite sure. Do we have a good baby? Do we not? We're not quite sure. We're going to continue to surveillance and reevaluate our baby. Once we've categorized the strip, this one kind of tells you what to do. So if you have a category 1, great, game on, routine management, let's keep going. Category 3, okay, we need to prepare for delivery. We're also doing our intrauterine resuscitation methods. Prepare for delivery most likely is going to be via C-section. And then category 2, we're still doing our POOF interventions or our intrauterine resuscitative measures. And we're really looking to see, what does our variability do? Does it go to absent or minimal? Then we're getting a little bit more worried, okay? But if we have moderate variability, even with some decels, remember, we know we have good oxygenation with that moderate variability. So it really looks at, what's our variability? What do we need to do? We always want to try to have a category 1 strip, but it's pretty rare in labor to have a patient stay in a category 1. Usually they move between the categories quite often, and we try to keep them as close to a category 1 as possible. All right, that's everything. In class, we're really going to practice these strips and go more into depth of reading them and what they mean and what we have to do. This presentation will cover information from Chapter 8 in our F.A. Davis book related to labor and birth. So when we talk about labor and delivery, we need to start off by figuring out what are some things that trigger labor to start, the natural, spontaneous labor. They found that there's maternal factors and also some fetal factors that can attribute to labor beginning. Maternal factors that they've found, once the uterus, the muscles of the uterine lining get stretched to the maximum capacity, then it can cause labor to begin. That, excuse me, causes oxytocin to be released. which then releases prostaglandins, which stimulates labor to begin. There's also changes in the amount of estrogen and progesterone. So the progesterone, if you remember from exam 1, if a woman has low progesterone levels, it can cause like a spontaneous abortion or preterm labor. Remember, we would start her on progesterone supplements in her pregnancy. Well, it's common, or what happens once you get to the end of your pregnancy, for the progesterone to drop, therefore putting you into labor. The fetus also can affect when labor can start. So there's changes in their cortisol level, which causes prostaglandins to increase, and the placenta also ages as we get closer to their due date, which can cause them to go into labor. Some different signs that a patient might experience that tells you that labor is soon going to happen, or impending signs of labor. We have lightening, and lightening occurs when the baby drops down lower into the pelvis. So if you ever look at a mom and where you hear someone say like, "Oh, it looks like your baby dropped," the technical term for this is lightening. You can see a picture of that on this slide here, where before lightening, the fetus is up higher in the pelvis, and after lightening, it drops down lower. Braxton Hicks are another sign of impending labor. These are false labor contractions. So they are contractions, but they don't cause your cervix to dilate. Usually they stop if you do different things to get the contractions to stop. You might notice some cervical changes. The cervix can dilate a little bit. It can get softer, a little bit shorter. Loss of the mucus plug. There's a picture of the lovely mucus plug here on the slide. This is just mucus that accumulates inside the cervix. It helps offer a barrier so no infections or bacteria can get up into the uterus. And so as the cervix dilates just a little bit, it causes that mucus plug to come out. They can have a change in their vaginal discharge. They might have more, less. Usually it's a little bit more. Nesting is when the mom gets a sudden burst of energy and just wants to clean and get everything ready for the house or for the baby. She might notice a weight loss. Okay, usually she loses about 3 to 5 pounds in the last few days before delivery. This is due to her body getting ready for labor. So she's going to have some, maybe some diarrhea, some looser stools, just to make more room for this fetus to fit. She can experience a lower backache. She can breathe easier, especially after lightening occurs, when that baby falls down lower in her pelvis. It's not up into her diaphragm, or doesn't feel like it's up in her lungs. And she's going to now have to pee more because that baby's really right on top of that bladder, causing frequent urination. So there's 5 different P's or factors that can affect the process of labor and birth. So first, let's define what labor is. Labor is defined as the progressive cervical dilation and effacement with regular uterine contractions. Okay, so to be in true labor, we need to have, your cervix needs to dilate, and we need to have regular contractions. Now there's 5 different things that can affect how good, how fast, how easy labor and birth can go. And of course, they all start with P's. So we have passenger, passageway, position, powers, and the psychology or psyche. We'll talk about each of these. So powers is made up of the primary and secondary powers. Primary is the uterine contractions, okay? It's the primary part of labor. This is involuntary, so you can't just say uterus contract. It does it on its own. The secondary power is mom's pushing efforts. This is voluntary, meaning she has control over this part, how good she's going to push, how hard, how effective. This is how she can contribute or affect her labor and delivery. Now with pushing, we've got open glottis versus closed glottis. What is recommended for moms is that when they're pushing, that they actually have an open glottis, meaning that they let air flow through their vocal cords as they're pushing. So you're going to take a deep breath in and they're going to push and you're going to hear a noise come out. Okay, so this is going to sound weird, but it's ooh. Okay, so you might have heard, or you still might hear it, but it's no longer best practice. They might say, take a deep breath in, hold it, and push for 10 seconds. Okay, release all the air, take a deep breath, hold it, push for 10 seconds. That's what we used to tell moms. They found that when we do that, it actually causes decreased oxygenation to get to the fetus and mom, and it increases the amount of CO2. Therefore, if we let a little bit of the air out, it helps with those factors. Now, I have on here some different words for you for powers related to the contractions. We have frequency, duration, and intensity. We will go over this later on, same with resting tone, later on in one of the other slides. So I have the definitions on here, but I'll explain it a little bit more when we talk about contractions. And then just some other things to know is, so dilation is the enlargement or the opening of the cervix. This is where it goes from 0 centimeters all the way up to 10 centimeters. That's when we say they're fully dilated. Effacement is the shortening, softening, and thinning of the cervix. So not only does it dilate, around to 10 centimeters, it thins out. So it starts off at about 4 centimeters in length when she's not in labor, and then when it's time to have the baby, when it's time to deliver, it's 100% effaced, so it's down to 0 centimeters. Our next P stands for passage or passageway. This is the most important determinant if the fetus will deliver vaginally, and what this relates to is mom's pelvis. Okay, the birth canal. So we have our pelvis, the cervix, the vagina, the introitus. When you're looking at a patient's pelvis, there's 4 different types of pelvis that she could possibly have. We have gynecoid. This is the best type of pelvis to have, the most favorable for a vaginal delivery. Then there's android, which is kind of more like a male pelvis. Okay, anthropoid, and then platyploid. Okay, so gynecoid is the best. Platyploid is the least common, kind of like not very favorable for a fetal head to fit through. Now, we don't really know what type of pelvis somebody has initially, but if, for example, if they go into labor and the baby just doesn't fit and we can't get the baby to come out and they do a C-section due to, sometimes they'll say CPD or cephalopelvic disproportion. Baby's the head is not proportionate to mom's pelvis, CPD. If that's the case, mom might have a different type of pelvis than the gynecoid. So then future pregnancies, it would be recommended to just do a C-section right away because you can't change your pelvic shape. What you're born with is what you got. Other things with the passage or passageway is that we look at with the pelvis is we look at the fetal station, and this is the relationship of the presenting part of the fetus to mom's ischial spines. In class, I will bring a pelvis for you to see, and I'll show you what the ischial spines are. But if that presenting part is right at the ischial spine, this baby's at 0 station. If it's higher up in the pelvis, it hasn't reached the ischial spines yet, they're negative numbers. Okay, so -1, -2, -3. If it has come down below the ischial spine, so it's getting closer and closer to being born, we're now positive numbers. So if it's 1 centimeter farther down than the ischial spine, we're +1. +2 is 2 centimeters. Once you get to +5, that means the baby's crowning. And what that means is if you look at mom's perineum, you see the top of baby's head coming out of the vaginal opening. Once the fetus gets to a +2 station, so 2 centimeters further than that ischial spine, it initiates this reflex on a mom. It's called the Ferguson reflex. This is an urge to push. Okay, so you can see this in moms, more often in moms without any pain meds if they're doing it natural, that all of a sudden they just, I have to push, I can't stop. You know, it's a reflex. It's just initiated, and it's something that they do once that baby gets low enough. Moving on to our next P is for passenger, and this is the passenger is the fetus. So things that it looks at is the skull size of the fetus. Okay, so you know, we can look at where the fontanelles are, if it's in the correct position. We can look at fetal attitude. So is the fetal head flexed, so chin down, or is it extended? Fetal lie looks at if the fetal spine is the same way as mom's spine. So basically, are we longitudinal? So is it up and down, or vertical? Okay. Or does it go sideways? Is baby in there transverse, sideways? Okay. Fetal presentation, that relates to what's the first part that is coming out of mom. Okay. Is it cephalic, meaning that it's head? Is it breech, meaning that it's either the butt or feet? Is it a shoulder presentation? So the shoulder is the first thing coming out. That's something that we need to know, as a shoulder presentation is really going to stall out our labor and delivery because it won't fit that way. And then the fetal position itself is all about what fontanelle, or where the skull or the face is located. So we prefer a fetal position to be in OA. You'll hear it referred to as OA, and that means the occipital, baby's occipital bone is anterior on mom. And again, I'll show you this in class. It's easier to show it than explain. So when you think about OA, occiput anterior, so the back of baby's head is to the front of mom's body. So if she were delivering, when baby comes out, if it's in the OA position, its face is going to be looking down, down at mom's butt. Okay. OP would mean that baby's occipital bone is on mom's posterior. So if that's the case, if baby were to come out this way, OP, when it comes out, its face would be looking up more at like mom's urethra. So the best position for baby is OA. Okay, that's the easiest way for it to fit within mom's pelvis, leads to, you know, like less pushing efforts and everything like that. You can deliver OP, but it's a lot more difficult, and pushing can take a little bit longer. Okay, the psyche or psychology, this is related to mom's emotional response to her labor and delivery. So we look at her anxiety level, her pain level. Does she have any fear? Anything like that. Some factors that can affect her labor progress could be her culture. Every culture has different ways that they deal with labor and delivery, different expectations, or maybe pain relief that they use to help the mom deal with labor. Expectations, like what is mom's expectations? Did she have a, you know, expectation that this labor was going to be fast and not painful? You know, something like that. What's her support system? Does she have a good support system? Other factors, any transgender, is this adoption, age, so adolescence, things to think of, how was this baby, you know, conceived? Okay, was it planned, unplanned, stuff like that. It can all really affect mom's emotional response to her labor. And the last P of things that can affect labor and delivery is position. This is mom's positioning, okay? Anything related to the fetal positioning is back on our passenger P. Okay, so this position is all about moms. We want mom to move. Okay, movement helps so much. Not only does it help with mom's pain with labor, but it also helps get that baby to reposition and move down lower and get into the correct spot for labor and delivery. So we should try to use upright positioning as much as possible as we can during labor to help use gravity to pull that baby down. During the second stage of labor, which we'll talk about here in a little bit, that's the pushing stage. Okay, it's time to push this baby out. It's really important to try to have mom in an upright position. This decreases her total length of pushing time, decreases how much extra oxytocin we have to give if we need to. Fewer medical interventions are needed, so like an episiotomy or the use of a vacuum or forceps to help deliver the baby. There's greater satisfaction reported by the patients, and there's also better oxygenation of the fetus. So on this slide, there's a whole bunch of different positions that can be used for labor. And remember, we don't want a pregnant lady, to ever be in a flat on her back supine position. And this just shows you what happens to the vena cava with that extra weight of the fetus and the placenta and the uterus and the amniotic fluid pushing down on those vessels. Okay, so that was our 5 P's. Now we need to figure out how we know if a patient is in true labor or false labor. True labor means that contractions are occurring at regular intervals and they increase in frequency, duration, and intensity, and it causes cervical dilation. Okay, so true labor, yes, we're definitely in labor. We can't stop it. False labor means that we're having some contractions, but they're kind of irregular, okay? And it doesn't lead to cervical change or very little, minimal cervical change. So when you're looking at the difference of it, true labor, usually the contractions get stronger, they last longer. The pain is felt in the lower back. Walking can increase the intensity of the contractions. And you might notice some what we call bloody show, which is a little bit of blood coming from the cervix dilating. False labor, we have irregular contractions, so they might be, one now, one in 6 minutes, one 2 minutes after that, one 10 minutes later. There's no pattern. They might complain of the pain in their abdomen or really no pain at all. It doesn't intensify. Their cervix doesn't change in dilation and there's no bloody show. So when you're in true labor, there's nothing we can do that can stop it. False labor, what we can do is we can see, okay, does labor stop? So for example, does it stop if she rests? Does it stop if she walks? If she drinks something or hydrates herself? These are all things that could cause some false labor to occur, more of just an annoyance, those Braxton Hicks false labor contractions. Something else that can happen when a mom goes into labor is her water can break or rupture of membranes. So if a patient comes in and complains of or thinks that her water broke, the first action we want to do, our priority action, is to check our fetal heart tones. Okay, so hook her up to the monitor and see what her baby looks like. Because what can happen is if her water does break and it comes gushing out, the umbilical cord could come gushing out with the water too, and it could now become occluded, or we call it a prolapsed cord, which is cutting off all of our blood supply and oxygenation to the fetus. So a priority action, hook her up to the monitor. Once she's hooked up to the monitor, then we can now assess to see, is it truly her water that's broke or not? So there's 4 different tests that we can do to see if it's her water that broke. The first one is called ferning, and there's a slide on this slide here, the one that looks like little, I don't know, ferns, right? Like you're looking at a a bush, tree, plant, a plant. That's what ferning is. So you would collect some of the fluid, you'd put it on a little microscopic slide, and then look at it under a microscope. And if it's her water that's broke, it's going to look like this plant can't talk, plant pattern. AmniSure is another test we can do. This is kind of like a COVID test. You swab the fluid, you put it in a little vial, and then you put some drops of this fluid onto, another thing, and it'll say yes, it's amniotic fluid or not. Nitrazine can be used. This is pH paper. You just touch it to some of the fluid, and if it's amniotic fluid, it will turn a darker blue. And if it's vaginal secretions, if it's semen or anything like that, it will turn yellow, acidic. You can also just use a speculum and look to assess to see if you see any fluid coming out of the cervix itself. So there's 4 different ways we can test. We want to know, but remember that our priority is to look at our heart tones first. So fetuses are really cool, you guys, when mom does go into labor. They go through these, we call them the 7 cardinal movements of labor. So it's 7 different things that the fetus does to align itself correctly, to fit through mom's pelvis and expel out into the outside world. So we've got engagement. So this is where the fetus goes up against the cervix, okay, and causes some engagement. And this also will cause the cervix now to start dilating. Descent, it starts moving down lower into the pelvis. The next one is flexion, and this is where it tucks its head, its chin down to fit. Then it internally rotates. You see how it's going to, this would be the OA position that we want. Moves its way down, and then it does extension. So once the head, which was flexed, once it delivers, it now extends. And then the baby does an external rotation, so it turns so that its shoulders are now lined up and downwards with mom, and then expulsion means it's born. So you're going to want to know these 7 different movements and kind of what they each mean. There's a little mnemonic here. Every day, fantastic infants enter real earth. That's one way to remember the different the order that these go into. All right, let's start talking about actual labor. So those are things that can kind of like lead up to labor, occur. Now we're going to look at these different stages of labor. Stage 1 of labor is broken down into different phases. This is the longest part of the labor process. Stage 2 can also potentially have 2 different phases. And then we have stage 3 and stage 4, which we'll talk about. Bottom right of this slide lists a nice little visual representation of the different stages and phases of labor too. All right, stage 1, phase 1. This is also referred to the latent phase. This itself is the longest part of labor. This phase can last 9 to 12 hours. It's when the cervix goes from 0 centimeters up to 5 centimeters. During this time, the contractions become stronger, more regular, more frequent, okay, getting to about every 2 to 3 minutes or so. The patient is excited and very talkative during this phase. The pain is usually, it's tolerable, and it's the beginning of labor, and she's just excited to meet this little baby. So some interventions that we can do during this stage and phase of labor is to really encourage non-pharmacological pain options. The reason we want to do non-pharmacological at this time is because if you do give pain meds too early in labor, it can prolong our labor process. And if we prolong it too much, that increases our risk of needing a C-section. So really just try to encourage mom as much as possible, maybe to get up and move around. We could use a birthing ball. Um, there's a whole bunch of different things that we can do for this non-pharmacological. We'll talk about it on the next slide. Diet, hydration, keep hydrated, okay? If she's able to eat, keep eating. Labor takes a lot of calories, so we want her to have some energy, especially when it's time to push. Make sure that she is going to the bathroom frequently. If her bladder remains full, it's going to keep that baby up higher in her pelvis and not be able to descend down where we want it. Education. This is a great time to provide education because they're excited. They want to learn during this time. Safety, okay, mom safety and also the fetal safety. You're going to monitor fetal heart tones and vital signs during this time. Review mom's prenatal chart, see if anything is concerning, and lots of documentation during this time. Some moms can do this phase at home. It's encouraged if they can, because then they can eat and drink and move around, and they're a little bit more comfortable at home. So some examples of non-pharmacological management of labor discomfort that they can use. So relaxation and breathing techniques. Massage or effleurage. So what effleurage is it's a rhythmic circle motion that you like rub on their belly. That's what that pink picture is on this slide. Counter pressure, so put in some pressure on their lower back. This really helps with a baby that's maybe in the wrong position, like an OP baby. They have a lot of lower back pain. Hydrotherapy, so sitting in a tub or a shower if able. Warm or cold packs. Guided imagery. So this is where you'll hear people say, like, imagine your cervix is a flower and it's blooming, it's opening. Acupuncture, acupressure, lots of different positioning, aromatherapy, continuous labor support. So get the partner involved, the family members, if they have a doula or anything like that, get them involved. Another thing to look at in different cultures is yin and yang. So they look at labor, as maybe maybe it's a hot, okay? They like the hot things during labor, and then maybe afterwards they want cold packs, or it's very common in different cultures to have different traditions that they do with hot and cold, or they only eat, cold food at this time and hot food at this time. Once the patient gets to be 6 centimeters dilated, she now moves into stage 1, phase 2. This is the active phase of labor. So this is where we say she's in active labor. So phase 2 is 6 centimeters all the way up to completely dilated at 10 centimeters. This moves more rapidly than the first phase. They usually dilate at about at least a centimeter an hour. If this is their second, third, fourth baby, it can be much quicker than that. Some common findings or complaints the patient might have during this time: they're going to have decreased energy and fatigue. Think that first phase of labor can last 9 to 12 hours. Okay. Nausea and vomiting is very common, especially as we get to 8, 9 centimeters. Have an increase in bloody show, so you'll notice an increase in bloody vaginal discharge. They could be trembling. They'll be like, I'm not cold, why am I shaking? It's their body's way of conserving energy to help them conserve some of their blood for when they deliver. They might get that strong urge to push, especially if that fetal head is at that +2 station and initiates that Ferguson reflex. And this is intense pain. So these patients, if they're going to want pain meds, it's probably during this phase. And if they're doing it without pain meds, more power to them. But they might need to really focus, and they're not going to be excited and talkative during this phase. So interventions, we're going to continue to assess her heart tones and vital signs, assess her pain, try to promote some comfort measures as best as we can, and encourage her to keep breathing and try to relax as much as possible. If the patient does request some pain medications, we have a couple of different options. Fentanyl or other, like sometimes morphine you might see, are medications that are offered. These do cross the placenta, however, and can cause respiratory issues in the newborn. Okay, so it crosses the placenta. What we get worried about with this is that, remember, a side effect, you guys, of fentanyl is respiratory depression in anyone. Okay, if you overdose on fentanyl, you're going to stop breathing. Remember that a fetus does not need to breathe in utero, so we're not worried about it respiratory depression when it's inside a mom. But if our baby is born too soon after giving mom fentanyl, once it's born on the outside world, it's not going to want to breathe. Okay, so that's what we get worried about. So if we're going to give her fentanyl, if we're going to give her a morphine, we want to do it earlier on in this phase 2 of labor. So maybe 6, maybe 7 centimeters, because we want to have enough time for that to get out of the system before this fetus is born. Nitrous oxide is another option. This is laughing gas. You may have had this before, like if you're, I don't know, getting sutures or at the dentist. This is something the mom can hold over her face with a mask, breathe in. It doesn't necessarily take all of her pain away, really. It kind of makes her think she's not having pain. Some women like it, some don't. Some common side effects are nausea and vomiting, dizziness, and drowsiness. She can use this at any time. It wears out of her system very quickly, so we're not worried about it affecting the newborn at all. But this is an option for her to try. Some hospitals have it, some don't. Local is another pharmacological option. So this would be like taking lidocaine. This would be more so if they need to cut an episiotomy. They could give her a shot of lidocaine right on the perineum before they cut her. Or they'll also use this afterwards if they need to do any sutures. Regional are the more common ones. A pudendal block is kind of interesting. They take a very long needle and it goes up to hit the pudendal nerve. So they have to go up through the vagina, and it's kind of by those ischial spines in a way. But it helps relieve the pressure, the pain feeling that they feel in their perineal area. Epidural is the most common. We will watch a little video on an epidural placement and kind of talk about what's important as a nurse with an epidural, what we need to do. A common side effect is that it drops a mom's blood pressure afterwards. So we want to preload her with some extra fluid before we have the epidural placed, so that hopefully we can counteract that from happening. A spinal is something that is common to be done for a C-section. It's kind of like an epidural, but it wears off, where the epidural is connected to a continuous a pump, like a PCA pump. So it gives her pain medication the whole time until we shut it off. Whereas spinal is a one and done. So she gets a shot, nothing stays in her back, and it wears off within a few hours. And then our last type of pharmacological options would be if we need to put mom to sleep with general anesthesia. This again is more for like an emergency C-section, or if during the section it's, you know, her epidural or her spinal anesthesia is not working and they need to convert to general to put her to sleep. They prefer not to do this during a pregnancy because it also puts the fetus to sleep. It transfers through the placenta. So if they do need to do general anesthesia, they need to get that baby out as quick as possible once mom goes to sleep. I just wanted to mention some of the nurse and interventions that you are responsible for when a patient does get an epidural. It's very important that we give a fluid bolus before the epidural gets placed. This will help counteract the common side effect of a drop in her blood pressure after it gets placed. We also want to make sure we have a good set of baseline vital signs and what our fetal heart tones look like beforehand, because we want to be able to notice if our vitals are changing at all, or if our fetal heart tones are changing after it. Have the patient get up and void before this is placed. as she won't be able to get out of bed once she has it, and also she won't be able to feel if she needs to void. Therefore, she will need some sort of Foley or a straight cath later on, but if we could prolong the amount of time that she would need that catheter placed, that can help. Make sure that the consent is filled out and signed by the patient and the anesthesiologist. Then you're going to position the patient for placement. This is usually a seated position where she's hunched over and pushing her back out think of like a cat curling a little bit. It could also be if she's laying, side laying is another option. Once it's all placed, this is a picture of how long the epidural needle is here, and I'll show you some in Skills Lab. I actually have a kit for an epidural so you can see the needle. But then you're going to lay her down and just a slight tilt. Again, remember, we never want her flat on her back, so just a little bit of a tilt. We're doing frequent vital signs afterwards. Like when I say frequent, I mean sometimes minute. Okay. We're also doing continuous fetal monitoring. And then if it's needed, we would place that straight catheter or a Foley catheter later on. Okay, so once we get to 10 centimeters, we're completely dilated. We now enter the second stage of labor. So this is the pushing stage. Okay, this is from when she's completely dilated all the way up until we deliver the fetus. If the mom has an epidural, we can then break this up into two different phases. Okay, so a latent phase of this is the early phase of our second stage of labor. This is also known as laboring down. So sometimes moms get to complete, okay, there's no cervix left, but they have no urge to push yet. So what could happen is instead of having mom start to push and get tired and worn out, we can have her labor down or let her uterus, that power, that primary power, push that baby down with contractions on its own for a while until mom feels that urge to push. Once she feels the urge to push and she starts actively pushing, she's now in the active phase of this stage of labor. Again, we have that open versus closed glottis pushing that I said before. Pushing itself can last up to 2 to 3 hours. Things that affect how long you have to push for. Have you had any previous babies? Do you have any pain medication? What's your anxiety level like? How big is this baby? These can all factor into how long you have to push. How strong are your contractions? How often are they? How good of a pusher you are. The other thing with pushing when we're talking about closed versus open, so we want to do open glottis, okay? And the way that you want to tell mom to push is we're going to take a deep breath in and we're going to push for about 6 to 8 seconds, okay? Let the air out. What's left? Take another deep breath in, push 6 to 8 seconds. You're going to do that with each contraction, and you should get about 3 to 5 of those pushes with each contraction. Okay. As a nurse, the interventions or the things that you're going to do during this stage of labor is you need to educate her on how to push, monitor heart tones in response to her pushing. Okay, it's very common to see some decelerations during this time. Offer comfort measures, perform perineal hygiene if needed, keep her bladder empty, so if she's unable to void, she might need a straight catheter placed, and really encourage the support person to be involved as much as possible. The third stage of labor begins after the baby is delivered, and it goes it stops once the placenta is delivered. It can take up to about 20 minutes, should not take longer than 30. So the baby's out, we're just waiting for the placenta to deliver. Some signs that signify that the placenta is ready to deliver, there's 3 different signs. First, the uterus is going to rise up into a ball shape. The umbilical cord is going to lengthen, and there's going to be a sudden gush of blood. If you notice those 3 things, it's a good sign that the placenta has detached from the uterine wall and it's ready to be delivered. During this phase, during this stage of labor, a medication that we give moms is oxytocin, and we give it at a very, very fast rate. Oxytocin, we know, can cause contractions. Okay, we can use it in labor to help, or in induction to help speed things up. But what we use it for afterwards, since we give it so fast, is we really want that uterus to contract down into a ball. This helps prevent a postpartum hemorrhage from occurring. There are some other medications or uterotonics we can give instead of oxytocin or in addition to oxytocin. So there's 3 of them listed on here: methergonavine, carboprost, and misoprostol. We'll talk more about this when we talk about the postpartum exam for exam 3. During this stage of labor, we're also monitoring mom's blood loss. So we need to look at an EBL, which is an estimated blood loss, versus QBL, which is a quantifiable blood loss. So it's really best practice now that we're doing QBL. So we're actually measuring how much blood. An EBL, estimated blood loss, we just estimate. Like we would look at something and say, oh, that's 300, milliliters of blood, but it's not a true representation. So now they either recommend collecting blood. You could see this when you're at clinical. There's a drape that goes under mom. It's called an under buttocks drape that will collect all the blood and measure it. Or we can also weigh everything, like the Chuck's pads and everything like that. Once we get that placenta to deliver, we enter the 4th stage. This lasts for about the first 2 hours after delivery. It's also the start of what we call the postpartum period, okay? The time of frame where she's no longer pregnant anymore. And the interventions that we do during this time is the provider will repair any lacerations. We are doing fundal assessments, so we're looking to see where that fundus, the top of the uterus, is at. Frequent vital signs, we're assessing the lochia, which is the vaginal bleeding. Measuring blood loss. We're encouraging mom to bond with baby during the golden hour. This is the first hour after delivery. It's recommended that the baby is left skin to skin with mom during this hour, and trying to get her to breastfeed the baby, if that's her plan for feeding the baby. And then also putting some ice packs on her perineum to help with any swelling or pain or anything like that. So sometimes there might be a reason that we need to start contractions or stimulate contractions to begin before labor begins on its own. This is called induction. So we're deliberately stimulating contractions to induce labor. This can be done for elective reasons or medical. So elective would be, there's no medical reason that we need to induce mom, but maybe she just wants to be induced that day. So there's new recommendations out there. One of them is to say don't do elective inductions, but most doctors will, as long as the mom is at least 39 weeks and there's no issues or anything like that. Medical indications, though, that we would start or induce a mom, there's a whole bunch of reasons. Maybe there's a little bit of a placental abruption going on. Okay, so we talked about an abruption in exam 1. Remember I said sometimes they're not so bad where we can try to have mom have a vaginal delivery. So once it starts slowly abrupting off, we could try for a vaginal delivery. Other indications would be chorioamnionitis. This is an infection that's within around the amniotic fluid. Fetal demise, so we have a stillbirth. Hypertensive issues. Premature rupture of membrane, so this would be mom's water broke, but she's not in labor. If she gets to 41 weeks or more, this would be a medical reason to induce her. Or if there's fetal compromise, so our heart tones aren't looking great, our baby is IUGR or something like that. Not everyone is a candidate, though, for a labor induction. There are some contraindications. So if mom has either a vasa previa or a placenta previa, so remember, we can't deliver vaginally with the previa. So why would we give her medication to stimulate contractions? A transverse fetal lie, so if that baby is laying in there sideways, again, we're not going to be able to deliver vaginally, so don't cause issues. An umbilical cord prolapse, so the umbilical cord has fallen down below baby's head. A previous classical cesarean birth, so a classical incision would mean that the incision goes vertically on mom. If mom has an active genital herpes outbreak, if she does, we don't want to deliver vaginally. So again, let's not induce labor to begin at that time. And then a previous myomectomy. A myomectomy is an incision in the uterus. So these would all be contraindications of us not inducing labor. She should have a C-section instead. So when it's determined that a patient should be induced, what we need to figure out, it's called her Bishop score. The Bishop score will help us determine which method or which medication we should use to induce her. So a Bishop score looks at 5 different things, and it scores her in each of these categories. The first thing it looks at is how dilated she is. Then they look at to see where the cervix is positioned. Is it, very posterior? Is it anterior? They're looking at effacement, so how thick or thin that cervix is. The station, meaning where baby's fetal head is at, related to those ischial spines, and then the consistency of the cervix. So is it firm? Is it soft? Anything like that. So they'll look at all 5 of those things, and they'll add up her score to figure out what her Bishop score. A Bishop score of 6 or greater tells you that the cervix is favorable. If it's less than 6, it's unfavorable. So if we have an unfavorable Bishop score, again less than 6, we need to get that cervix ripened or ready before we start causing a whole bunch of contractions. So there's some mechanical things that we can do to help. Basically what we're trying to do is just mechanically dilate the cervix a little bit. So there's laminarias or Cook balloon catheters. So a laminaria is down on the bottom right of this slide. And what it is it's basically dried up seaweed that gets placed inside the cervix, and it will start absorbing that cervical mucus, and that causes it to expand. It's kind of like a tampon if you think of it in a way. Okay, but it goes right in the cervix, not just in the vagina. So as it expands, it forces that cervix to dilate open. These are not very common at all. I've seen them once in, I don't know, 13 years. The other newer thing that you'll see is called these Cook catheter balloons. That's what the other picture is. So it's like a Foley catheter, but instead of only having one balloon, there's 2 balloons. So one balloon goes inside on next to baby, and one goes on the outside of the cervix. And you fill both of them up, and then that causes that cervix to get like squished together, and it starts thinning it out. And then it also puts pressure on the cervix to cause it to dilate a little bit. There's a higher infection rate with this because you're leaving something in place, right? A nice mode of transportation for bacteria to get inside a mom. They stay in place for about 6 to 12 hours. But a good thing with these is that there's no medications, meaning that we're not causing contractions, causing a lot of stress on our baby at all. There are medications. So instead of using mechanical agents to ripen the cervix, we can use different medications. So we have prostaglandins. Okay, prostaglandins are also found within sperm. So that's a good way to tell patients if they would like to, start labor off, go have intercourse, sperm can help. But if that doesn't work, there's 2 different types of prostaglandins that we use within the hospital. The first one is called dinoprostin or Cervidil. That's what a picture of this on this patient's hand is. The end rectangle part there, the thicker part, that has the medication itself in it, and that's going to get placed right next to the cervix. The rest of it, the string, is just for a way for you to be able to pull that out if we need to. The other medication is misoprostol, which is a pill. It can be taken a whole bunch of different ways. It can be placed vaginally, orally, buccal, a whole bunch of different ways that it can be used. So these two medications, they're not used together. You use one or the other. They're placed to help the cervix ripen. It might stimulate some contractions. Some risks with using either of these would be that it could cause tachysystole, too many contractions. It could cause uterine rupture, the uterus to rupture. It can also cause fetal heart tone issues because we're causing contractions. Every time we contract, it cuts off that oxygenation to our fetus. Because of the risk of a uterine rupture, it is not to be used in women who have a history of a previous scar on their uterus. So patients that have had a C-section or any other incision into their uterus are not candidates for these cervical ripening agents. So if our patient has a Bishop score of 6 or more and her cervix is favorable, we can start off with our big gun, the most common induction agent used worldwide, and this is oxytocin. So this is a medication we give through an IV that stimulates contractions. There are risks with this. Since we're stimulating contractions, we might stimulate too many and cause tachysystole. We could also lead to a failed induction of labor, like maybe it's just not working. It can lead to fetal heart tone issues, and another side effect is water intoxication. It retains water when you're using this. This is a high alert medication. Must administer this with a pump. We're going to start off at a very low dose, and we're going to titrate it until we achieve the desired contraction pattern, which is usually about 3 contractions in 10 minutes. The goal of oxytocin is to use the lowest dose possible to achieve about 0.5 centimeter to 1 centimeter per hour dilation. Once we get into a good active labor pattern, we can stop oxytocin, okay? Or at least we can cut it back into the lowest dose possible. Some other things that we can use during labor, sometimes these are used to induce in a way or just kind of help stimulate labor to move along, is to break her water. The breaking of the water is called an amniotomy or ARUM, artificial rupture of membranes. So this, you take this little hook here, there's a little sharp point at the end, and you nick the bag of water. And amniotic fluid, when it releases, it increases the conversion of prostaglandins, which causes you to go to contract. The fetal head must be engaged. And what I mean by that is that it must be low enough in the pelvis so that nothing can get around it. Again, I'll show you this in class. Breaking of the water is contraindicated in patients with HIV because you could nick some blood with it that way if they have hepatitis or an active genital herpes. Risks with breaking of the water is variable decelerations, and we'll learn about that in a little bit, bleeding, umbilical cord prolapse, and now we're also increasing the risk of an intraamniotic infection. We no longer have this fetus in a sterile environment surrounded by a bag of water. We've gotten rid of that. All right, Chapter 10, Complications of Labor and Delivery. Okay, some other things that we can see in labor and delivery, or this one is actually before the patient goes into labor, is called an external cephalic version, an ECV. This is done if it's noticed that the fetus is in an incorrect position. Okay, so either it's breech, it's transverse, or something like that. If they notice this, what they can try to do is try to rotate the fetus to the correct position to increase the likelihood of a successful vaginal delivery. This is usually done in women who are not laboring, and they do it close to term because there are some risks that go along with it. Patients who would not be candidates for this would be ones who have placental abnormalities, so like a previa. Doesn't really matter what position our baby's in with the previa because we're not going to deliver vaginally anyways. If there's an abruption going on, we're definitely not going to want to be putting some forceful, I don't know what the word is I'm trying to think, but we're not going to be trying to force this baby to turn around. As a nurse, what is our role during an ECV? We want to look at our baby, so monitor heart tones before they do the version and then also after. Okay, so these moms hang around for a little bit afterwards. If mom is a negative blood type, this would be an indication to give her RhoGAM. And then a lot of times before they do the version, the provider will ask for a tocolytic to be given. Okay, so It's Not My Time. One of them was a terbutaline. This is the medication that they would administer before a version. What that's going to do is it's going to relax the uterus, making it not contract as they're pushing on the baby trying to get it to rotate. So it can make it a little bit easier to get that baby rotated. Other things with the version, an IV is always good to have, because what can happen with this is as they're trying to rotate this baby, we could rupture her water and we could cause a cord prolapse, which we'll talk about in a little bit here. If that's the case, we're doing a stat C-section. So versions need to be done in the hospital. We need to have an OR crew readily available in case we need to go back to the OR right away for a stat C-section. All right, let's jump in now to the new material for chapter 10. So we're going to talk about a couple different types of dystocia. Okay, so dystocia basically means that the labor and delivery isn't progressing as we would expect, as it would be normal. And it can be due to a couple of different things. So labor dystocia, slow, abnormal progression of labor. This is the leading cause for a patient to end up as a primary C-section. It can be due to abnormal power. Okay, so think power is our contractions. So maybe our contractions aren't strong enough or frequent enough. Power also consists of mom's pushing. So maybe she just can't push very well. It can also be due to the passenger, the fetus. So maybe it's in there the wrong presentation, so fetal malpresentation. It could also be due to the passage or the passageway, mom's pelvic shape. So maybe she has what's called CPD, cephalo, baby's head, pelvic, mom's pelvis, disproportion. So baby's head does not fit through mom's pelvis. Other reasons that we could have labor dystocia could be due to extreme fear or anxiety or exhaustion by mom. Also, if she gets pain medications too early on in labor. So think of when she's 2 centimeters and we give her an epidural. We've talked about how important movement is to have labor progression and everything like that. If we do pain meds, not only will it confine her to bed, but it can also relax the uterus and make the contractions be not as strong. Another word or way you might have heard of this labor dystocia is failure to progress. She's failing to progress in labor. So there's a few different types of dystocia that can occur. So we know it's a dysfunctional, abnormal, kind of prolonged labor, but it can be contributed to some different things. So the first type of dystocia is uterine dystocia. This is weak or uncoordinated contractions that occur in labor. This can either be due to hypertonic, meaning too strong of contractions, or due to hypotonic, too weak. So if a patient has hypertonic contractions, they're frequent and painful, but they're ineffective with her dilation. There is a risk for exhaustion from the mom, also exhaustion for the uterus. And this can also lead to fetal intolerance because every time we have a contraction, we're cutting off that blood supply and oxygenation to our baby. It can also lead to asphyxia issues. This is common in first-time moms. Our interventions, we're going to try to slow down her contractions. So hydrate her, control her pain, promote rest, continue to assess the fetal heart rate to see if anything else needs to happen. If we have hypotonic, that means we have weak contractions that aren't causing any cervical change or really slow cervical change, so less than a centimeter an hour once we get to active labor. This can also lead to risk of exhaustion and infection, fetal intolerance to labor and asphyxia. It's more common in multips or patients with extreme fear. And our interventions is we can try to make more contractions. So we can augment her labor with oxytocin, break her bag of water, or we might have to perform a C-section. Okay, so if we're looking at dystocia, another type that we can talk about is uterine dystocia. This is where the slow labor progression is due to the uterus. So we either have weak or uncoordinated contractions in labor. So we can either have hypertonic or hypotonic contractions. Hypertonic means that they occur frequently, okay, and they're painful, but they're ineffective with dilation. So she's having them, but they're just not effective. This can lead to exhaustion for the mom. It can also lead to fetal intolerance of labor and asphyxia, because every time we have a contraction, we are cutting off that blood supply to our baby. Therefore, if we keep doing this to baby, it's going to cause issues. This is common in women who've never given birth before, nulliparous. Interventions, if this is happening, we want to kind of slow down those hypertonic contractions. So hydrate mom. Help her manage her pain. Promote rest and keep an eye on what your fetal heart rate looks like, what your fetal heart tones are doing. So the other type of contractions would be hypotonic. These are weak contractions with no cervical change. So once we get to active labor, okay, so once we're at 6 centimeters, we expect about a centimeter an hour. Well, this would be we get to 6 centimeters and we're not getting that. Again, this can lead to risk for exhaustion because it's prolonging our labor. It increases the risk for infection and also fetal intolerance. Same thing, to fetal intolerance to labor and asphyxia. This is more common in patients who've had babies before, or it's even very common in patients with extreme fear of their labor. Interventions for this is we might need to give them some oxytocin to kind of make those contractions stronger. This should say AROM, artificial rupture of membranes, so breaking her water. Or if we just can't get her to get into a good labor pattern, she might need a C-section. Sorry for all the yawns today. Okay. Our next type of dystocia that we're going to talk about would be arrest of labor. Okay, so this would be an active phase because we're in that active phase of labor. We're at least 6 centimeters dilated. Okay, but now we're not changing. Okay, so arrest of labor is defined as we're at least dilated to 6 centimeters, our water's been broke, and we've had no change in our cervix, and it's continued this way either for 4 more hours with adequate contractions or 6 or more hours with inadequate contractions. So one of the things that they might do for this before they say, oh, we need to, call it quits and do a C-section is they might actually want to see how strong those contractions are. So this is where they would place one of those intrauterine pressure catheters, those IUPCs, to actually see how strong the contractions are, to see what the Montevideo units are, the MVUs. And if our MVUs are 200 to 300, we know that that's considered adequate contractions, which should be making cervical change. If we're less than 200 for MVUs, then we know our contractions aren't strong enough yet. We need to get them stronger in order to see cervical change noted. If this is the case, we can do something called labor augmentation. This is where we augment, so we enhance the labor that's already started by supplementing the contractions to increase their strength and frequency after spontaneous labor has started. We can do this with the use of oxytocin or by rupturing the membranes, okay, breaking her water. A second stage of labor disorder, so we get to complete, it's time to push, okay, but now it's taking too long. It's a dystocia, okay, or labor isn't progressing like we want. So we can call this a prolonged second stage. This is where, for a first-time mom, it's diagnosed with a lack of progress for 3 hours of pushing with an epidural, or if she doesn't have an epidural, it would be 2 hours. And a mom who's had babies before, it would be diagnosed after she's been pushing for 2 hours with an epidural or 1 hour without. So the amount of time that a patient needs to push can be affected by a whole bunch of different things. First of all, how many babies do they have? Okay, the more babies that a patient has, the less amount of time that she'll have to push. Did we do delayed pushing? Okay, so did we let her labor down a little bit? If that's the case, if we let her labor down for an hour before we had her start pushing, that could help make her push less. Does she have an epidural? If so, it can make pushing be about an hour longer than someone without an epidural. What's mom's BMI? What's the birth weight of this baby supposed to be? Is it a bigger baby? What position is this fetus in? The position that we want our baby to be in is an OA position. That means the occiput, baby's occipital bone, okay, is to mom's anterior. So basically that means when baby's head delivers, if it's in the OA position, it's going to be facing down towards mom's butt. OP position means the baby is facing up. This makes it more difficult for the baby to fit correctly through the pelvis and can lead to longer pushing for the mom. Sometimes what they will choose to do with this prolonged second stage is try using an operative vaginal birth device, either the vacuum or the forceps, before they would say, nope, let's go back for a C-section. Here are just some different, that OA and OP that I was talking about. This kind of shows you how baby would be in there. And then the other thing I put on here was if we are having prolonged pushing issues with their mom, we should be trying different positions, especially if we know that our baby is in maybe is in OP position. If we have mom reposition, try pushing in different ways, that could actually help rotate the baby while it's still inside of mom to make it be easier for her to deliver. Okay, our next type of dystocia is fetal dystocia. So this is where something with the baby is holding up this labor, making it take longer. So this could be caused by an excessive fetal size. So maybe, this is a, 12-pound baby. If that's the case, the baby would stay up higher in mom's pelvis and not be able to descend at all. Therefore, maybe keeping the cervix from dilating, or if she does get to complete, maybe it won't descend within the vagina at all. Could be due to malpresentation. So maybe baby's in their breech. Okay, if that's the case, that could keep baby from descending, as same as a big size. Multi-fetal pregnancy, so maybe more than one baby in there. Twins. The twins could kind of hold each other up higher in the pelvis, therefore not descending one at a time in order to have a delivery. Maybe there's fetal anomalies. Okay, so here's a picture of a baby with, oh, brain fart here, where their head is bigger, okay, than what we would expect. So that could keep baby from fitting through the pelvis. Some complications that can occur due to this fetal dystocia is neonatal asphyxia related to a prolonged labor, fetal injuries like bruising, maternal lacerations, and then here comes that CPD, that cephalopelvic disproportion. So the baby is just not going to fit within mom's pelvis. Okay, so an operative vaginal delivery. This is something that can be done. So this here is the vacuum, the picture of it here. The indications for this is to improve maternal or fetal status by shortening the second stage of labor. So let's say mom's been pushing, you know, we're at 3 hours with an epidural and she's just exhausted. She just can't do it anymore. Okay, so the provider could recommend, you know, let's try putting a vacuum on and helping assist with the delivery. Maybe mom is unable to push effectively. Maybe she has some sort of cardiac disease in which she shouldn't go through the strain of pushing. Again, the prolonged second stage, arrest of descent, meaning that baby just isn't coming down more in the pelvis. Or sometimes it's used for non-reassuring fetal heart rate. So we need to get this baby out fast so we can try using the vacuum to speed it up. So in order to use the vacuum, there's a couple of things criteria that must be met. First, the fetal head must be engaged and mom has to be completely dilated. Her water has to be broke. Her bladder should be emptied. She should be at least 34 weeks. We have a rule. It's called the three-pull rule, meaning that the provider is only able to use the vacuum and pull 3 times with it within 15 minutes. If that is not successful, the nurse needs to notify the provider, hey, we've met our limit, our cutoff here. You should not do it again. And then they should remove the vacuum and either let mom continue on like with the vaginal delivery if she can, or go back to the OR and do a C-section. Sorry for the noise, my dogs are running around me here. Something you can see with the vacuum delivery is what's called a pop-off. This is where the vacuum, as the provider is pulling on it, it pops off. It comes detached. That's a sign that there's too much pressure exerted on the fetal head. I will bring some vacuums to class for you guys to be able to look at them and apply them on your arm and feel how much pressure is applied by one of them. There are some risks for the fetus if this is something that's used in delivery. There's a risk of a laceration on their head, the development of a cephalohematoma, an intracranial hemorrhage, and then they're at an increased risk of hyperbilirubinemia or jaundice. Another option that can be used instead of the vacuum are forceps. Forceps are not used quite as often as the vacuum, but some providers still use it. It's used for the same indications as a vacuum. Again, the fetal head must be engaged. Mom has to be completely dilated. Her water has to be broke. And they can use it to help shorten the second stage of labor. I see I have another spelling error there. There's a little bit more risks here because it's a metal device. Okay, I'll bring this to class for you guys to look at. They kind of look like salad tongs to me in a way, or salad tossers. So placing of these forceps inside a mom can cause lacerations. She might need an episiotomy to be cut. She can hemorrhage. She can have a perineal hematoma, trauma to her bladder, or even develop a perineal wound infection. The baby can experience issues or side effects. They could have a facial laceration, some facial nerve palsy, corneal abrasion, skull fracture, and intracranial hemorrhage. So there's definitely risks that need to be told to the patient, and they need to give consent in order to use either one of these. Another type, pelvic dystocia. This is where everything looks great. Okay, the fetus is great, great position, everything like that, but it just can't descend through the pelvis. This can be due to mom having a small pelvis or an abnormal pelvic shape. So remember back to week 5 when I was talking about the different types of passageways for our successful vaginal delivery, and I said the gynecoid pelvis was the best and the platyploid was the worst. So if your mom has a platyploid pelvis, that could lead to pelvic dystocia, where the baby just can't fit through it. How we would know that this is going on is we would just monitor the fetal descent and station. So is that baby moving down? Is it getting to zero station at the ischial spine? Or is it, not descending and staying up in those minus numbers? The last type of dystocia is considered an obstetrical emergency, a shoulder dystocia. This is the one that most people fear. It is unpredictable and unpreventable. Okay, you don't know who's going to have a shoulder dystocia and who's not. Basically, what happens is the head delivers, but then the shoulders get stuck behind mom's pelvic bone and keep the baby from advancing and being able to deliver the rest of the body. One of the signs that we see with this is called the turtle sign. This is where the fetal head delivers and then it slightly retracts back against mom's perineum, just like a turtle head coming out from its shell and then going back in, like hiding. That's kind of what happens with shoulder dystocia with the fetal head. Risk factors that a patient might experience a shoulder dystocia: if she is pregnant with a large baby, if she has diabetes, if she has a history of shoulder dystocia, prolonged second stage of labor, and if mom had excessive weight gain. So if you start seeing that or seeing some of those risk factors, then you want to be ready in case this does happen. Some complications that can happen to our mom: this can lead to severe lacerations. It can cause her symphysis pubis to separate. It can cause sphincter injuries, which later could lead to incontinence, infections, bladder injury. It could also lead to a postpartum hemorrhage. For a baby, it's going to lead to increased intracranial pressure. Okay, that head is delivered and now it's kind of getting suffocated in a way. Anoxia, asphyxia, neurological injury, death, brachial plexus injuries, and clavicle fractures. So if this happens, what do we do? So what do we want to do if we see that turtle sign and we realize we have a shoulder dystocia? First of all, you want to take a deep breath and try to remain calm. Okay? You need to be calm so that you can get the patient to remain calm. Call for help. Okay, you're going to need additional help for a couple of reasons. One, if you can't get the baby out vaginally after doing different interventions, they're going to have to take this patient back to the OR and try to get the baby out doing a C-section. The other reason you want additional help is because this baby is going to be compromised. The head is stuck outside, the body's inside. Okay, all this extra squeezing of what's going on with the baby is cutting off the blood supply and oxygenation. So even if we can deliver the baby vaginally, it's going to come out very stunned and probably need additional support. So you're going to want a NICU team there. Okay, hopefully your mom's bladder is empty. Okay, you want to really keep that bladder empty during labor and delivery, just because that bladder can cause the baby to stay up higher in the pelvis or cause issues like this. So if it's not empty and you can tell it's full, they can try to throw a Foley catheter in to empty it, but it's going to be a little bit awkward. Then what the provider will tell you to do is what's called the McRoberts maneuver. So you're going to straighten the legs out and then bring them back. You're going to flex them onto the abdomen. And then you're going to make a fist and you're going to push down right over mom's pelvic area. We're going to do suprapubic pressure. Ideally, you're going to push from the side that is on a baby's back. Okay, so if you look down a mom's perineum and you see which way baby's facing, you want to go to the side that would be the back. And you're going to push down, strong, steady push. You might even need to get up on the bed and push. Now, not like CPR compressions, but one good constant pressure push. The idea of this is to try and get that shoulder to curl in a little bit more. It's usually that anterior shoulder up on top that's stuck behind the pelvic bone. So if you can cause it to curl inwards and then pop out from underneath that pelvic bone, you've just dislodged a shoulder dystocia. Now, you do not want to do fundal pressure. We don't want to push down up on the top of the fundus, as that can lodge our baby in there even more. If suprapubic pressure doesn't work, some things the provider might be doing is they're doing their own little maneuvers, trying to rotate baby. They might cut an episiotomy. That's not what's holding our baby in, okay? But that just gives the provider more room to manipulate the baby. You can try repositioning mom. So flip her over, hands and knees, anything like that to see if that will work. The provider, one of the moves they might do is where they go in and hook baby's clavicle and break the clavicle. Okay, it sounds horrific, but it can save the baby's life. So any babies that experienced a shoulder dystocia after they're born, one of the things we want to look out for is any broken clavicles or that brachial plexus nerve damage or anything like that. Lastly, if we cannot get this baby out vaginally, even after all of our attempts, and we're at 5-6 minutes of this going on, we've got barely any time left before we have a dead baby. So they can do what's called the Zavanelli maneuver. This is where the provider will reverse the cardinal movements of labor that a baby does and basically tuck the chin, rotate the head, push it back up into mom's pelvis and do a C-section and deliver it that way. When this is done, the outcomes are not great for baby, okay, as it's very traumatic, and we've also had a shoulder dystocia for minutes. So these babies are not going to come out great. All right. Next, labor and delivery complication that can occur. Precipitous labor and birth. The definition of this is rapid labor that lasts less than 3 hours from when it starts to when we have the birth of the baby. Now, some women say they would love to have this. If I could only be in pain for 3 hours, I could do it, right? I wouldn't need pain meds. I could do it all natural. Okay, good for you. Go for it. But these women experience a higher pain with this type of labor, and their anxiety level is way higher just because everything's going so fast. They're also at an increased risk for a hemorrhage after having a baby, and the baby itself is at risk for hypoxia. So some risk factors that a patient might experience a precipitous labor and birth would be if she's a grand multip, meaning she's had more than 5 babies before. Also, if she has a history of a precipitous delivery. So what do you want to do if this is happening to your patient? Okay. A lot of times these patients are the ones that are going to come wheeling in, okay, They were at home, labor started, an hour or two ago. They didn't want to come in too early because, they've heard labor can take forever. So they waited out at home. They come in and you see them wheeling in the wheelchair and they're sitting sideways. They can't even sit straight down on their bottom because they're complete and their baby's about to come out. Okay, that's most common, I would say. But what do you want to do if this is the case? Well, first of all, remain with the patient. Okay, that baby is most likely coming and you're not going to be able to stop her from wanting to push when it's time. Monitor your baby's heart rate and uterine contractions. So try to get your monitor on. Assess her labor. So what is she dilated to? Okay, do a vaginal exam. Try to offer support. Okay, talk to her. If she's gonna have a precipitous birth and it's gonna be a nurse delivery because the doctor doesn't get there in time, you're really gonna want that patient to be able to listen to you and trust you. Anticipate that this patient's gonna hemorrhage afterwards and anticipate bad things for your baby, that hypoxia. Okay, so have extra people in the room. Have your medications readily available for a hemorrhage. And then prepare for delivery. Okay, try to get the room set up quick, get what you need. Remember, take care of yourself first, so proper PPE for you before you go and catch a baby. Okay. Okay, let's talk about some of the obstetrical complications. If I haven't scared you enough yet to never want to get pregnant or go through labor and delivery, you might be scared after these next 9 slides. Okay, post-term pregnancy. So this technically means if you're over 42 weeks gestation. There is a increased risk of perinatal morbidity and mortality. Okay, the risk of bad things, death for mom or fetus, dramatically increases once we get to 42 weeks. Some risk factors that a mom might, that she has that might put her at risk for a post-term pregnancy would be if it's her first pregnancy, if she has a history of a previous post-term pregnancy, if she's carrying a male fetus. That was interesting to me. The men just, don't want to come out. The boys want to stay inside their mom. And maternal obesity. So what can happen? What are risks for mom and baby? Well, increased risk of stillbirth, increased risk of macrosomia, so a big baby, shoulder dystocia, needing a C-section or an operative vaginal birth. Mom can hemorrhage. Mom can develop an infection. Oligohydramnios. So what happens, the placenta was only made to work for about 40 weeks. After 40 weeks, it starts having little mini strokes within it and cutting off the blood supply. So there's a picture over here of a calcified placenta. You see all those white spots? That's all dead tissue, dead blood vessels within this placenta. Therefore, we're not getting blood supply and oxygen to our baby, which therefore the baby is no longer going to be perfusing blood to its kidneys, therefore no longer voiding or making any amniotic fluid, leading to oligohydramnios. This can also lead to neonatal seizures, meconium aspiration syndrome, which we'll talk about here, and low APGAR scores. So they highly recommend inducing labor at 41 weeks and not letting it get to 42 weeks. Okay, meconium stained fluid. So this is where baby poops inside a mom. So normally babies do not have their first bowel movement until they're on the outside of mom. But if they experience some sort of fetal hypoxic stress, okay, so let's think of some things that could stress our baby out. Maybe mom's blood pressure tanks and we now, drop her blood supply to baby. That could cause it to poop itself. Maybe certain drugs. Maybe mom develops an infection. Maybe just labor itself is causing it stress. Okay, or post dates. Okay, the baby's held its poop in so long, It's not supposed to have to hold it in for much longer than 40 weeks. And now we're at 41, 42 weeks. And it's, sometimes when you got to poop, you just got to poop. So that happens. The reason that this is concerning is because that meconium can be aspirated by the fetus either in utero or during delivery. And when it's aspirated, it gets within the lungs and it coats the alveoli. So normally in utero, those alveoli don't need to expand because there's no air in there. But now once it's on the outside world and it takes its first breath, if those alveoli are coated with meconium, they can't expand. Therefore, it leads to respiratory distress that can be life-threatening. It can lead to airway obstruction. So they just can't breathe appropriately. So normally amniotic fluid is clear. When it's MEC stained or meconium stained, it'll either have a green color, a brown color. You could see little particles of meconium in there. If that's the case, you want to notify the neonatal team that you have meconium because you're going to want them there at time of delivery. You need to have somebody who is trained on how to intubate a baby in case this goes bad. Okay? Now, a lot of times everything is fine, but there is that risk that this baby's respiratory distress can become life-threatening and we need to intubate. When the baby's born, if it's thick MEC, what they can do is they can take the bulb syringe and suction the mouth and then the nose. Remember, M comes before N in the alphabet, mouth before nose, to help get that meconium out. So when the baby does take its first breath, it doesn't have a mouthful or a nose full of poop, and it doesn't inhale that into the lungs. Multiple gestational birth, so if you're pregnant with twins or triplets or anything like that, just a few things. Risks, so these patients are at an increased risk of delivering preterm. Remember how we talked about once your uterus is stretched so far, it can cause you to go into preterm labor. That's more common with twins or triplets. Labor dystocia, so the labor's not progressing how we want it. This can be due to abnormal presentation. The babies just are lodged against each other, not coming down on the birth canal like we want, which may lead to a C-section. They're at an increased risk of having a placental abruption, which can lead to a hemorrhage, so have meds readily available. And they're also at an increased risk of stillbirth. So stillbirth or intrauterine fetal demise, IUFD. This means a fetal death after 20 weeks of gestation. Okay. Risk factors that a patient might experience IUFD. African American, nulliparity, advanced maternal age, obesity, pre-existing diabetes or chronic hypertension, smoking or alcohol use, pregnant with multiples, a male fetal sex, so having a boy, unmarried, and past obstetrical history. Okay, those are all things that put a mom at risk for a stillbirth. A stillbirth has, not only does it lead to, fetal death, but it also increases some issues with mom. It can lead to infection, sepsis, endometritis, which is an infection within the uterus, DIC, which we'll talk about on one of our last slides. If your patient does experience a stillbirth, okay, it's really important to, get help in there for the patient, especially if this was, unplanned or unknown or anything like that. Get some chaplains in there, get them support. You yourself be there for them. Encourage them to see the baby afterwards, hold the baby, take pictures. There's different things hospitals do. Sometimes they'll do like hand and feet molds. There's some photographers that will come in from Now I Lay Me Down to Sleep and will take pictures of demises. There's a whole bunch of different things. You could do like a lock of hair, just to really help those parents as much as they can deal with the situation. Okay. Intraamniotic infection or chorioamnionitis. So this is an infection that also has inflammation of the amniotic fluid, placenta, fetus, fetal membranes, or decidua. Common findings that would make you think that your patient has chorioamnionitis. So mom has a fever, okay, 38 or greater. Okay, we're getting a little worried. Mom is tachycardic or baby's tachycardic. Okay, if you ever see your baby to that's baseline start going up and we're above 160, check mom's temperature. There's a very good chance that if she doesn't have a temperature by now, she will shortly. Okay. Mom's WBCs will be elevated. Her uterus will be tender. It's infected. Okay, so if you touch her belly, it's going to hurt her. And the amniotic fluid is going to have a distinct odor to it and kind of be like pussy in a way. If your mom does develop chorioamnionitis, what we get worried about is that infection will also get to our baby. Depending on where mom is at in her labor, they might let her continue on with a vaginal delivery if we're close. If not, they would recommend a C-section. Think of why we would want to do a vaginal delivery in this case. Okay. Do you think it would be a good thing with an infection in your uterus to now take a patient back and cut in to that uterus and make a wound? Okay, that won't heal as well. If your patient does get diagnosed with chorioamnionitis, you're going to administer antipyretics, so Tylenol, and antibiotics to help control this. Maternal obesity, just want to list some things that it increases mom's risk for at time of delivery and during labor. So an abnormal progression of labor can take longer. It can lead to fetal macrosomia, shoulder dystocia, higher rates of operative vaginal delivery and needing a C-section, increased risk of a hemorrhage, and it can also lead to difficulty tracing your fetal heart tones and the contractions. If that's the case, they might recommend doing internal monitoring. So like we talked about in week 5, that fetal scalp electrode or that intrauterine pressure catheter, they might need to place. Okay, cord prolapse. I kind of mentioned this earlier with AROM, with that amniotomy. So what happens with this is that umbilical cord presents first. You can either see it visually hanging out of the vagina, or it can be invisible. You don't quite see it hanging out. Okay. If it is hanging out, so you see a cord hanging out of mom's vagina, couple things. One, try not to touch it, play with it, or anything like that, because what will happen is it will cause it to constrict, okay, and it will not function correctly. So if it is hanging outside, you want to take a wet, sterile gauze or a wet, sterile with saline, towel and wrap it in there. You want to keep it moist, okay? You don't want it to dry out at all. And this is an emergency situation, like we're going back to the OR. Now, typically it occurs when the water breaks and when the presenting part is not engaged. So remember when I said back for the AROM, it's really important that that presenting part is engaged. This is why. Because if not, when that water breaks, that cord can come down and come out first. If that happens, the circulation of that umbilical cord gets occluded and it results in fetal heart rate issues. So we'll either start seeing variable decelerations, prolonged decelerations, and then eventually it will become bradycardic. It'll just stay down. If you see that, what you want to do is you want to check your patient. Okay, so put on a sterile glove, check and see if you feel a cord. It will feel like a pulsating. You'll feel the pulse. Again, don't keep touching it or anything like that. But if you do feel one, what you're going to do is your hand is going to stay inside of mom. If you find a cord, you keep it. And what I mean by that is your hand stays inside of mom and you're going to push up on that baby's head to try and relieve that occlusion. And you're going to ride back to the OR this way. and you're going to leave your hand in there until that baby is delivered via C-section. Now, you can also, if this happens, you can also flip mom into a couple different positions. You can try Trendelenburg. You can do face down, butt up, like this picture over here, but really to try to use gravity to get that fetal head to come off of that cervix. Risk factors that a patient might experience a cord prolapse. If the baby's in their malpresentation, okay, so if it's not head down, there's an increased risk of that cord's going to prolapse when the water breaks. A smaller baby, an unengaged presenting part, a whole bunch of fluid, polyhydramnios. Multiple babies. Well, multiple babies, we have multiple cords, and also it can lead to the babies not being in the right presentation. Preterm breaking of water and a grand multip. Those all put her at risk. Uterine rupture, again, a very scary and emergent thing that can happen. Most often this occurs in women that have a history of a uterine scar or an incision, and they come in and they're in labor. It can also occur, though, with tachysystole or the use of prostaglandins, so our misoprostol and dinoprostin. Can also happen with trauma to the abdomen, so a motor vehicle accident or a fall or abuse or a gunshot wound. That can all lead to that uterus rupturing. So it's just like a balloon that we explode, okay? If that's the case, our fetus is no longer within a uterus, it's just free floating within the abdominal cavity, and we're having no blood flow to the placenta because it's no longer connected at all to the uterus. So we have got a few minutes to save this mom and also save this baby because it leads to a massive hemorrhage. These moms a lot of times will complain of feeling this tearing sensation. So they can feel that uterus start to tear. You'll see uterine tachysystole on the monitor. Mom will start showing signs and symptoms of shock. So, pulse will increase, blood pressure will drop. You'll start seeing changes in your fetal heart tones. Initially, it might go a little tachy, just like mom's pulse increases, but then it will tank. And then also, if you go and check your patient, let's say your patient was 4 centimeters, 40% zero station. Okay, you go and check her. A, there's no cervix left. And B, that fetal head is no longer at that station. It's now floating up higher because that uterus is not keeping it there and pushing it down. So we call that an ascending station. Again, this is an emergency C-section. And what they're going to have to do is a hysterectomy because there's no uterus left. They can't piece that back together. An amniotic fluid embolism. Out of all these things that can occur during labor and delivery, this is the one that scares me the most. This is very rare, okay, but it's life-threatening and it can occur during pregnancy, labor, birth, or the first 24 hours after birth. It's unpreventable and unpredictable. So this is usually what happens when you hear of a patient who completely healthy, no issues. They, went in for labor, they had a baby, and all of a sudden they died. Okay, it's most likely due to this AFE, amniotic fluid embolism, or anaphylactic syndrome. So what happens is amniotic fluid gets into the maternal bloodstream. Now you would think that amniotic fluid is within a female's body and that it should be compatible, right? It's not compatible with the female blood. It causes massive release of mediators which cause a pro-inflammatory and pro-coagulant reaction. This leads to acute pulmonary hypertension, right ventricular failure, acute respiratory distress, DIC, and then left ventricular failure. Symptoms that would make you think your patient is experiencing an amniotic fluid embolism: sudden dyspnea, hypotension, cardiac arrest. If you're looking at them, they might appear cyanotic. They'll have a change in their LOC, uncontrolled bleeding, and possibly even seizures. Risk factors that a patient puts them at a higher risk for an AFE, advanced maternal age, pregnancy, multiple pregnancies, placenta previa, labor induction, C-section, an instrumental vaginal delivery, cervical or uterine trauma, and eclampsia. So just think of the things that could occur during labor and delivery where they could nick a blood vessel, okay? And now some of that amniotic fluid can get into that blood vessel. So a vaginal delivery, a lot of women experience some sort of laceration or episiotomy. As you experience that and you're delivering, you're still leaking out amniotic fluid. So there's a potential that amniotic fluid getting in that blood vessel. C-section, you cut mom open, you're exposing a lot of blood vessels, and that amniotic fluid comes right over those blood vessels as they take the baby out. So if you think your patient is experiencing this, what are you going to do? You call a code, okay? Because you are going to need a team there. There's no real treatment. It's all supportive measures. But she's going to end up coding on you very fast and you need help. If this occurs during the pregnancy, so let's say she's still pregnant, what they're going to do is they're going to have to do a stat section. Usually we'll call this a post-mortem C-section because mom, if she codes, she's dead, okay? They're going to cut her open right there on the bed, get that baby out, and then try to save mom. The reason they do that is because trying to run a code on a patient who's pregnant, all that extra blood that's needed to go to the placenta and everything like that, if we get that baby out, we now have better circulation within our mom herself. So a lot of times these patients, they will cut her right there on the bed, get the baby out, try to save the baby, and then focus on mom at that time. And then lastly, what can happen? So if you have an AFE or even if you start hemorrhaging, you can go into disseminated intravascular coagulation, DIC. This is where the body is breaking down clots faster than it can form one. This quickly depletes the body of clotting factors, and you just start hemorrhaging and oozing out of every orifice of your body. DIC has to be triggered by something else. So it's not just like, oh, hey, I am in DIC. You go into DIC because of something else that happened. So either mom had a placental abruption, lost all that blood, we've used up the clotting factors to try to stop that abruption. Now we don't have any clotting factors left. Okay. Same with maybe she had an amniotic fluid embolism. Maybe she's septic or preeclamptic or HELP. Or any other type of massive hemorrhage can throw her into DIC. All right, that's all for this week. Hope I didn't scare you too much. All we have left for next week is C-section care on Chapter 11, and then I'm going to put in a little bit from Chapter 10 in there related to a VBAC and a TOLAC. It kind of goes along with that, but it's not much information that we'll need to cover for that. So the recording for that should be much shorter than this. All right, thank you for listening. Welcome to week 7, our final chapter, final little bit of information for exam 2 review. This is all on chapter 11, intrapartum and postpartum care of cesarean birth families. Okay, so about 30% of deliveries within the United States are performed via a C-section. It's kind of been on the rising lately, but really it's not recommended as the ideal route for delivery. So what we should be doing is trying to prevent the initial C-section from ever happening. So some different things they found that can help prevent or get our C-section rates to lower include the following. First, before a C-section is called for failure to progress, they really want the patient to have met the requirements for labor dystocia, which would be she's had to have been in labor for 6 hours, her water needs to be broke, she has to be having adequate contractions, her cervix should be at least 6 centimeters. If that's the case, and we go for this long, then they would, that patient meets the requirements for labor dystocia. And that's when they would say, okay, yep, it's not progressing, let's do a C-section. They encourage everyone to use standardized fetal heart rate categories. So our category 1, 2, and 3, and that's how we should be looking at fetal heart tones. Encouraging the use of cervical ripening agents for women with a low Bishop score. So remember, if we're 5 or less, we should be using the Cervidil or the Dinoprostin or Misoprostol. That can help prevent C-sections. Letting the women wait longer in the latent phase, so the early phase of labor, letting them continue in this phase for up to potentially 24 hours. If the baby is found to be in a breech presentation or in a male presentation, offering that external cephalic version before she goes into labor to help get the baby in the correct position. They encourage no elective inductions before 39 weeks. And they're also encouraging patients who are pregnant with twins to try labor out, especially if the presenting twin, is in a cephalic position. See if they can deliver vaginally that way. C-sections can be classified by 4 different ways. We have scheduled C-sections and unscheduled. Let's look at scheduled. Scheduled means that this is a pre-booked, we're going to do their C-section before they go into labor. So this would be for patients who have a history of a previous C-section or some sort of health condition, either maternal or fetal, that places them at risk during the vaginal delivery. If they have a breech baby and this was diagnosed before they go into labor, or then CDMR, this is cesarean delivery per maternal request. Like mom's like, nope, I don't want to have a vaginal delivery. I want to have a C-section. Scheduled C-sections, the patient comes in, again, not in labor at all. We're not in a rush or anything like that. So we can, make sure everyone is ready, make sure we get all the medications in mom and everything like that. Whereas unscheduled means that it wasn't pre-planned to have that C-section at that day. So unscheduled, it's more of a urgent situation. So we have 3 different types of unscheduled. We have emergent, urgent, and non-urgent. So an emergent C-section would be that we have an immediate need to deliver the baby. So think of it this way. This is like, I don't like to call them, but I've called them our like splash and slashes. So from when the doctor says we need to do a C-section to when we get that baby out, it's usually less than 20 minutes. So reasonings for this, like if we have a cord prolapse, a uterine rupture, category 3 tracing, abruption, something like that, where we have this immediate need to get the baby out. The next one is called an urgent. There's a need for a rapid delivery of the fetus, but it's not quite as fast as an emergent. Okay, so examples would be, let's say mom goes into labor and baby's in transverse position or something like that. It's male presentation. Or mom comes in with a known placenta previa with mild bleeding, okay, but our baby still looks okay, all right? We don't need to take her back and, bypass all the safety measures, but we do need to get that baby out fast. So the decision to incision time is less than about 40 minutes. The last type of unscheduled C-section is a non-urgent. This is where we know she can't deliver vaginally anymore, but there's no immediate need to get her delivered. Baby looks fine. So maybe she's, failure to progress, labor dystocia. She's been stuck at 6 centimeters now for 8 hours. Okay, we're not progressing. We're going to have to deliver her via C-section, but, we can kind of wait a little bit and see how things are going. So reasonings that a patient might need a C-section. So labor dystocia, like we had talked about, a category 2 or 3 tracing, fetal malpresentation, pregnant with triplets or twins, suspected fetal macrosomnia, so we're expecting a really big baby, History of a previous C-section. Maybe there's some sort of placental abnormalities, or there might even be some pre-existing conditions that, like a cardiac issue that maybe mom, shouldn't go through a labor process. Diabetes, hypertension, pre-E, stuff like that could all be reasons for a C-section. Something your book talks about is the additional risk factors that are placed on a patient if she needs a C-section and she has obesity. Obesity alone, we already know, increases the risk that the patient might need a section, as she might have failed trial of labor. She has an increased risk of developing endometritis, wound ruptures, dehiscence, and VTEs. But during a C-section, obesity increases her risks related to anesthesia. So they can have difficulty placing an IV, difficulty placing an epidural or the spinal medications. If that's the case, then they're going to have to put her to sleep and give her general. Now, if they have to give her general, they have to intubate her. There's issues with intubating women with a higher BMI. She's also at risk for aspirating if they have to intubate. So they try to, because of these additional risks, they really try to get women with a higher BMI to be able to deliver vaginally. So what is our role? Okay, when we're looking at the nurses' roles here throughout the next few slides, think of it for a patient that comes in for a scheduled C-section. Okay, there's no rush or anything like that. We know they're coming in. So perioperatively, okay, or pre-op, before they come in, before they enter the OR room. So when the patient presents, usually it's in the morning, you should collect or do a complete admission assessment. So, head to toe, collect baseline vital signs, collect baseline heart tone. So do an NST, see how your baby is. Make sure mom's filled out all the correct forms. Review lab work. If she hasn't had recent labs done, you're going to collect some. You're really interested in CBC, platelets, type and screen. Look through mom's chart. Does anything stand out significant that could lead to issues or complications? Document the last time she ate or drank anything. Should be at least 6 to 8 hours before her scheduled C-section. If she has ate before that time, let's say she's like, oh, I just went through, I don't know, Starbucks on the way here and had a coffee and donut. Okay, that's something to let anesthesia know, because they'll probably push back her C-section because of the risks of aspiration. Get an IV started and give her some fluids. Make sure she empties her bladder. Sometimes they'll say to insert a Foley preoperatively, but if there's no issues, they might let her wait until she's numb from the pain medication before they place it. And then there's also some medications that might be ordered to be administered. These ones help with aspiration. So like sodium citrate and sodium bicarb, some Pepcid, and then there's an IV antibiotic. The antibiotic should be given within 60 minutes of the start of surgery. So you don't want to give it too early. So sometimes they'll wait to give this antibiotic until the patient's like on her way back to the OR, just so that we don't give it before 60 minutes. Okay, then back in the OR, when you're back there with the patient, we got to make sure a timeout is performed. So that's going to make sure we have the correct patient, the correct procedure, the correct site. Assist the patient into the correct position for her medication. So if she's getting a spinal or an epidural or anything like that. Prep her abdominal skin. This is usually done with betadine or iodine wash. Remove any hair if there's any left. Okay. Apply a grounding device. So one of the things they use back in the OR is a cautery. So to make sure that the patient and the provider don't get shocked using this, you got to put a grounding device on. Keep the patient warm. It's very cold back in the OR, and you've just infused a whole bunch of room temperature fluids into her, so she's going to be cold. So get her some warm blankets. Put a Foley catheter in now if she's numb and doesn't have one. Position her and secure her onto the table. So she's going to be positioned with a wedge under her like right hip or right buttocks. That will tilt her onto her left side. Put on SCDs to help decrease her risk of blood clots. You're going to count instruments and sponges multiple times back there. Check fetal heart tones after the anesthesia has been placed, and then record times. So like the time the patient got into the OR, the time the anesthesia was done, the time that the incision was, all these different times. Some potential complications that can occur during the surgery in the OR. She could hemorrhage. There could be some trauma to the bladder, the ureter, or the bowel. She could experience respiratory depression and hypotension. Post-operatively, so once the doctor is done, you'll move her to the PACU. She'll stay here for up to about 2 hours or so. And you as the nurse, you're going to do her recovery. You're going to monitor her level of consciousness. She's going to be on frequent vital signs. So like every 2 minutes or so. She'll be on cardiac monitors. So you'll be monitoring that. Monitor her pain. If she has a dressing covering her incision, you're going to be looking for that, making sure there's no bleeding through of it. Eyes and O's. Monitoring her sensory and motor function. If she had an epidural or a spinal anesthesia, is she starting to be able to feel her toes, wiggle her toes, anything like that? Monitor her fundal height and lochia. We want to make sure her uterus now stays firm and it's clamped down where we want it. Make sure she's not hemorrhaging on us. Monitor for signs and side effects from anesthesia. So respiratory, itchiness, nausea, vomiting. Again, active warming, so get her to stay warm. Her Foley, you want to remove as soon as possible. Usually it's in with about 12 hours after she is delivered. Slowly advance her diet as tolerated. Oxytocin should be running in the immediate post-op care. Get her up walking as soon as she has feeling in her legs. So usually that's about 6 hours after. And then get her to bond with that baby as much as possible. So skin to skin, breastfeed, things like that. Complications that can happen after surgery include hemorrhage again, anemia. She can have a DVT or a PE. Paralytic ileus, so you want to listen to her bowel sounds, make sure that they're waking up and working. She could have blood in her urine due to trauma that her bladder gets. She could experience infections. And then a severe headache, that would be due to from the epidural or the spinal. Sometimes when they're placing the pain medications in through the epidural cavity, they puncture through the epidural space and it can cause a spinal headache. After she's done in the PACU, you move her to her postpartum room. And things that we would do for, up till the time of discharge, again, monitor her vital signs, assess breath sounds, encourage her to cough and deep breathe, assess her pain, treat her pain, keep monitoring her fundus and lochia, assessing for signs of hemorrhage and infection, get her up walking. DC when it's appropriate. So most women after a C-section stay in the hospital 2 to 3 days. Making sure that we're assessing those bowel sounds to make sure that she doesn't get a paralytic ileus. Chewing gum can help wake them up, so that's something that can be started post-operatively, and really provide education. So education that you want to tell your patient about is that's kind of specific to a C-section would be incisional care. So talk to her about signs and symptoms of infection of the incision. So, a temperature, drainage. You can talk to her about Rita. Explain what dehiscence is. If she has, depending on how she has her wound closed, if there's staples, those get removed on about day 3 after having the baby. Otherwise, the sutures will dissolve on their own. Talk to her about vaginal bleeding and what's normal. It should start off as a bright red bleeding, and then it will go to like a pinkish color and then to like a clear color. Tell her that if she's soaking a pad in less than an hour, that's too much bleeding and she needs to come back. Activity restrictions. So with that uterine incision, she shouldn't lift a lot. So most places will tell you nothing more than like your baby in a car seat. But she should get up moving around. Okay, you don't want her laying around in bed all day or anything like that. Get up moving, but no lifting, no driving, things like that. Again, encourage breastfeeding and talk to her about breast care. Nutrition to help her heal. Pain management, how is she going to deal with her pain when she goes home? You always want to talk to every patient about postpartum depression, the signs and symptoms and what's normal and what's not. And then also signs and symptoms of a DVT or a PE. So redness, warmth, swelling in the back of the leg or the arm. The PE would be, shortness of breath, change in her LOC, tachypnea, all sorts of things like that would be signs of a PE. So just because a patient ends up a C-section with one pregnancy doesn't necessarily mean the next time she gets pregnant she needs to have a C-section. What she can potentially try is what's called a TOLAC, a trial of labor after a cesarean. So this is where the patient attempts to deliver vaginally after having a C-section. Now, if it's successful and she was able to deliver vaginally, she then is considered a VBAC. That's a vaginal birth after cesarean. Why would we do this? Why should we encourage a patient to attempt a TOLAC? Well, there's a shorter hospital stay after having a vaginal delivery than a C-section. The recovery is actually shorter too. There's fewer complications like decreased risk of getting fevers, infections, DVTs. And babies that are born vaginally actually have fewer breathing issues. So it's kind of something that's encouraged to kind of see like, would you be able to have a vaginal delivery the next time? But it doesn't come without risks. Okay, so some risks of a patient attempting a TOLAC or a VBAC. There's that risk of the uterine rupture, so that uterus doesn't hold up where that scar tissue was and doesn't do well during labor and with contractions and tears open. Uterine dehiscence is like the same thing where that scar tissue starts tearing. This could lead to hemorrhage and it could lead to fetal death and even maternal death with it. Who would be candidates for a TOLAC? So not everybody should be given should be offered the opportunity or encouraged to attempt a TOLAC, but candidates would be patients with a history of one prior C-section with a lower uterine incision, a low transverse uterine incision. So you'll see on this slide here 3 different uteruses with different ways that the incision is cut. They need to have that top one. Also, to be a candidate for a TOLAC, you have to have no other condition that would require a C-section. So like a previa or male presentation or anything like that. And then where you deliver, there must be appropriate staff that is trained to perform an emergency C-section. Having an OR available, anesthesia needs to be readily available so that if one of those bad things happen, like a uterine rupture, you can get that baby out. It would be one of those emergent C-sections if that happens. We need to get that baby out within 20 minutes. Contraindications are things to keep in mind that would keep your patient from being a candidate for a TOLAC. Okay, so patients with a high risk of uterine rupture. So if their previous C-section was an up and down, a classical incision, that would kind of be a contraindication for them to attempt a TOLAC. If they have a history of previous uterine rupture, that would not be recommended for them to attempt a TOLAC. If they had a C-section the first time due to pelvic abnormalities, so let's say they got diagnosed with that platyploid pelvis. Remember, we can't change our pelvic shape, so they would recommend not even attempting to try another vaginal delivery. If there's any medical or obstetrical complications that would require a C-section, home births are not good candidates for a TOLAC or VBAC because they don't have the staff readily available to be able to perform a C-section if needed. And then also with these patients, we're going to use no cervical ripening agents. So no misoprostol or dinoprostin. Even if they're, if we need to induce them, okay, if their Bishop score is less than that 6 where we normally would use the cervical ripening, for patients with a history of a uterine scar, we do not use those just because of that risk of tachysystole and uterine rupture. All right, that is everything for this exam. Thanks for listening.